Welcome everyone to the Perth and Kinross Integration Joint Board meeting of the 26th of October. My name is Bob Benson and I'm the chair for today, and I'm looking forward to going through what's a very full and engaging agenda. So first of all, I'd like to note some of the apologies for the meeting.
Thank you, Chair, and good afternoon, members. We have apologies from Dr. Emma Fletcher and also from Graham Martin.
Thanks very much indeed. I've asked Scott out with the agenda to update us on potential board changes from NHS Tayside.
Thank you, Chair. Just to advise, I'm advised by the clerk to NHS Tayside Board that there's a meeting tomorrow to agree the following changes to the membership of the Perth and Kinross IGB. We have Dr. Jackie Jensen and Martin Black, who will be appointed as voting members from NHS Tayside. I understand Donald McPherson will be leaving as a voting member, and also we will be having a change in the proxy members from NHS Tayside. Graham Martin will no longer be a proxy member. However, the two members will be Donald McPherson and Dr. Andrew Thompson. So I believe, subject to approval at the board tomorrow, these changes will take effect as soon as possible.
Thanks very much indeed. That now takes us on to item 2, declarations of interest. Are there any declarations of interest around the agenda today? Okay. That then takes us to the minute of the meeting of Perth and Kinross Integration Joint Board of the 31st of August 2022 for approval. Can we check the accuracy of the minute, please, for comment? And before I move to proposing. I see that Sarah Dickey's got a comment.
Thank you very much, Chair. It was just in regard to the meeting of the last IJB in respect to comments made by myself with regard to presentation of the mental health services paper. And I wish to state that I'm not content that it represents those views expressed at the meeting.
Thank you. That will be noted. Can I ask that we clarify what your actual meaning was at some stage, perhaps? I'm going to ask Scott to come in as to how you go about doing this. Thank you.
Thank you.
Thank you, Chair. Sarah, if you wish, we may wish to pick this up out with the meeting and then we can bring it back to the next meeting if you wish.
That'd be perfect, Scott. Thank you.
Thanks.
Thank you. With that noting, can we now move to seek a proposer and a seconder for the minute? Beth Hamilton has proposed and David Illingworth has seconded. Thank you very much. That then takes us to item 4, action points update. Jackie, do you want to just update us on these? Thank you.
Yeah, thank you very much, Chair. In relation to action point 131, which relates to a financial framework in relation to the mental health strategy, Living Life Well, it was noted that work was continuing across Tayside, and I can confirm that a group to progress the financial framework will be a priority in the governance review that is set out in the mental health services update that will be received later. Thanks.
Can I ask Jackie, do you have a kind of timescale on when that might report back? That would be helpful.
I don't have that at this point in time, but I am committed to, in the recommendations to the IJB and the mental health services update, to be bringing back some more detail by the end of March.
Right, and will you give us an update on that position at the next IJB meeting as well?
Absolutely can. Yeah, thank you.
Want to go on to the next one?
Yep. And the next item is 137, which is a review of the mechanisms in relation to communication, and that has been delayed from this meeting, and it's proposed that the communications teams for NHS Teesside and Perth and Kinross Council will work together to bring something forward and share that in advance of the next IJB meeting for comment and approval. Thanks.
So thank you. So that will come to our December meeting.
Yeah.
Thank you.
138. 138 is a development session in relation to inpatient mental health overspend, roles and responsibilities, and it's proposed that that will be incorporated into the development session on the 16th of November. So that will conclude that action. And the next item, 139, in relation to membership and voting status around public partners and raising that at a national level. And I know that we've dedicated the discussion on at a meeting to be held on Friday the 28th of October this week to that matter with public partners. Thanks.
Thank you. And the final one, 140.
And that paper's on the agenda, so that item's complete.
Okay, that takes us to any matters. Sorry, am I on? It is on now. That then takes us to any matters arising which aren't on today's agenda, please. Okay, that then takes us on to item 6, delivering on strategic objectives. And Jackie, you're going to give us a verbal update on 6.1 Chief Officer Strategic Update. Thank you.
Yes, thank you very much. Paper 6.2 relates to the appointment of Chief Finance Officer, and this paper is being brought forward following the resignation of Jane Smith. Jane is moving on to a post within CHAS, which is Children's Hospice across Scotland, as Chief Operating Officer, and we'll be sorry to lose her. So it's with that note of sadness I bring this report forward. However, we want to move very quickly to ensuring that we have arrangements for that statutory role, and that we progress very quickly with the appointment to the permanent appointment to that post, and the arrangements for that are outlined in the report. And also the report is seeking authority to introduce interim arrangements to discharge that role in the very likely event that there will be a gap in the Chief Finance Officer position while recruitment is underway. and that has been requested because we are in a very critical position in relation to budget setting, etc. So, and if we are to move quickly on that, it will avoid any gap in this very critical role, and hopefully allow some handover as well, Jane, before you leave, which is likely to be at the end of December. Thank you.
I have a. If you could switch your mic off.
Sorry.
Still not on. Question from Councillor McCall.
Thank you, Chair, and thank you for that update, Jackie. It's just really a point of clarification in terms of recruitment policy. Is the recruitment policy that we only advertise for internal applicants?
I'm wondering if we should go on to that when we get to 6.2 formally, because you're still doing a verbal update at the moment, aren't you?
Okay, I can wait.
Oh, sorry, I've skipped the agenda.
Yes, I
Yes,
was.
you went on to 6.2.
Sheila, can you hold on?
Yes, I can hold, yes.
Sheila, can you hold on from that question? Raise it when we come to 6.2, please.
I will
Thank
do,
you.
yes.
Jackie, do you want to continue the verbal update? Obviously, that was an important part of the verbal update.
Apologies for that. Yes, in terms of the strategic, three important areas. I'm really not doing well with all my various bits of paper and technology today. I wanted to advise the Integrated Joint Board about the winter pressures and our readiness for that, and also advise that we received a letter on the 12th of October from, it was jointly signed by the Cabinet Secretary for Health and Social Care and Hamza Yousaf, and Cabinet Secretary for Social Justice, Housing and Local Government, Shona Robison, all about the support for the health and social care system in the light of current pressures being experienced across the NHS and social care. And as we head into winter, they describe the situation as very challenging nationally. And ministers are seeking significant reductions in delayed discharges and trying to return to the levels that had been sustained for the period of 9 months up to August of this year, and outlines the need for consistency and redoubling efforts in applying evidence-based practice to measures to alleviate winter pressures. So the Cabinet Secretary was seeking assurance about the readiness of our local planning and the measures that we were taking across the system to ensure a rapid reduction in the number of patients delayed in hospital. And a meeting was hosted yesterday for that purpose. And from the papers that are here today and brought forward in relation to our delayed discharge position and our discharge without delay improvements, the measures that the Cabinet Secretaries outlined are actually addressed very helpfully in the paper that will be coming to you and under discussion at item 6.6, so I won't go into any detail around that, but it's probably very timely that that report is before us here today. Also, the Health and Social Care Partnership has set up a command structure for addressing the particular pressures that are being experienced in discharge delays, and that's being led by Evelyn Devine as Head of Health. We're also being asked to continue our support for care homes through our Care Home Oversight Group, which was highlighted as good practice in the recent joint inspection report, and that will continue to offer timely access to professional support and clinical advice throughout the winter. And we're also making good progress to the recruitment to the Living Life Well teams, and exploring which will implement a new model in relation to social care in some of our rural areas. So I think that's particularly innovative measure, and something that others will be looking at very closely in the coming months. And we're also increasing or being asked to increase social work capacity to review care packages, and that's something that we will step up as part of the improvement work that Evelyn is leading, and you'll hear about that later. I'd also like to advise the Integrated Joint Board that we, in relation to developing the directions policy, that I'm pleased that we have had a workshop in September which involved members of the 3 health and social care partnerships, NHS Tayside Board and local authorities, about drafting an addendum to the directions policy, and it was hoped to bring that forward to this meeting, but that was perhaps a bit over ambitious, and the work is not concluded yet, but members should be assured that that work has commenced and that there is full engagement across all of the partners in that. And the engagement across the 3 chief officers and each of the IJBs is being strengthened as a matter, as a result of that work that we're taking forward. So those are the key things that I would like to draw to your attention today. Thank you.
Thanks very much indeed, Jackie. You've already alluded to some of the elements which are on today's agenda. If there are areas that are out with the agenda that folk want to ask Jackie about from her verbal update, I'm happy to take any comments or questions. Thanks very much, Jackie. And can we now move on to 6.2, appointment of the Chief Finance Officer? I think you've already given us a preamble to it, and I will take Sheila McCall's question when we get to that point. But thank you, Jackie.
Apologies for that, and I probably should apologise for any embarrassment that this causes Jane as Chief Finance Officer. And we just to say again that the report 6.2 addresses the issue of the appointment to the Chief Finance Officer arising from Jane's resignation as she moves on to a very exciting post in CHAS as Chief Operating Officer. And it's recommended that the Integration Joint Board notes the resignation of the Chief Finance Officer, which is a joint appointment by NHS Tayside and Perth and Kinross Council, and is a statutory post as part of the integration legislation, and seeking authority to introduce interim arrangements to ensure that there is, to avoid a gap in that crucial role of Chief Finance Officer while the permanent role is being filled. Thank you.
Okay, thank you. I'll now take Councillor Sheila McCall's question. Sheila.
Thank you, Bob, and thank you, Jackie. Mike, it was really a point of clarification about the recruitment standard practice, and is it normal to recruit only internally in the first instance?
Thank you, Councillor McCall, for your question. I think that will all depend on the current circumstances and in relation to the partner bodies. So I will take advice from each of the HR leads in relation to the current position for both NHS Tayside and Perth and Kinross Council at the point of advert. But I can't clarify that for you at this point in time.
Yeah, I think that the appendix assumes that the candidate will come from one of those 2 organisations, so that's the reason for the question.
I think it's really just to say that's to give opportunity across both NHS Tayside and the council to enable that to be a fair and a fair process and allow applicants across both organisations, because it is a joint appointment.
Okay, thank you.
Thanks, Jackie. And further question from Beth Hamilton.
Thank you. It's just again a point of clarity. You're talking about appointment of finance officer, finance man. What about the corporate services element? Will that be part of the interim and permanent arrangements? Thanks.
Thank you. The Chief Finance Officer role is the statutory function, which is why I'm bringing that here to the Integration Joint Board. In relation to the other aspects that Jane currently has, that would be something that we need to consider in terms of the management of that and where that would sit. Thanks.
Thank you. Colin, do you want to ask a question?
Thank you, Chair. I wonder if I could ask about what the arrangements intended for the assessment centre are, and who would be involved in that.
Those arrangements aren't organised as yet, but I can confirm that the panel will include both the Director of Finance for NHS Tayside and the Head of Finance for Perth and Kinross Council. They've already committed to that process. So I'll be taking advice from our HR colleagues in relation to the nature of that assessment centre. But it will include personality tests and presentations.
And I wonder if I could just check. So I'm aware of the nature of assessment centres that have happened under the HR policies of both NHS Tayside and the Council, and I just wondered whether that assessment centre would include a wider pool of people than the three on the panel. So, for example, members of the IJB, some of the public partners on the IJB, for example, whether that would be a wider process.
Yeah, that's certainly something that can be included into the assessment centre, and I would be keen to see that happens. Thanks, Councillor Stewart.
Thank you.
Any further questions on this matter before we move to recommendations? Okay, so the recommendations are that we note the resignation of the current Chief Finance Officer for the Perth and Kinross Integration Joint Board and the recruitment arrangements agreed by NHS Tayside and Perth and Kinross Council. And secondly, delegates authority to the Chief Officer to introduce interim arrangements for the discharge of the role of proper officer for the Perth and Kinross Integration Joint Board until the permanent role of Chief Finance Officer is filled. Do we agree? Nods of heads will do fine. Thank you.
Great.
Thanks very much indeed. Thank you. Let's now move on to 6.3 Mental Health Services Update.
Thank you very much, Chair. It's me again, and this is the second of the update reports on mental health services as a standing item for the IJB, and I'm pleased to bring this forward to this meeting. Please note that the content of this report will also be reported to a meeting of NHS Tayside Board tomorrow. So for those of you who are board members of NHS Tayside, you may have to read this twice. But it's very important that we have that level of transparency and reporting in relation to the strategic development of mental health services. The report follows a similar format from before and provides an update position in relation to inpatient mental health services, for which responsibility rests with NHS Tayside. Also gives an update on the coordination of strategic planning since that was provided in August, and an outline of the current position in relation to the Listen, Learn, Change improvement work and the work of the Independent Oversight and Assurance Group, which is led by Fiona Lees. You'll see in paragraphs 2.2 onwards to an update on inpatient services, starting with learning disability inpatient services, and you'll see that there the issues around delayed discharge, the complexity of need, and the workforce challenges persist. And at 2.6, it's noted that the Mental Welfare Commission visited the Learning Disability Assessment Unit in Carsview on the 24th of May. That report was published last week, and that's now available on the Mental Welfare Commission's website. The report is indicating that the work to progress dedicated provision or a single site model for learning disability inpatient services and to accelerate the discharge of long-term patients it's essential that is an urgent work stream within the Living Life Well strategy, which is outlined at 2.13. So really just advising that needs to be progressed as a matter of priority. From 2.8, there's an update on general adult psychiatry inpatient services. Again, the challenges of demand and capacity persist, with services experiencing high levels of occupancy. They continue to be beyond the Royal College of Psychiatry's recommended levels of 85%, and you'll see there that they continued into August over 100% over the summer, and the actions to reverse that will require whole system change. And at 2.10, the issues around workforce and where there are deficits in registered nursing workforce are outlined, and the actions to improve the situation are outlined in the report. And I'd like to advise that the appointment of an additional clinical director role in an interim capacity, this is an additional role providing additional capacity, and I'm advised that will now move to a permanent advert for that position. So that will help to increase medical capacity and the move from the dependence on locum and interims to interim medical cover. And also the findings of a Mental Welfare Commission report into the modern ward at Murray Royal Hospital has been published last week too, so you'll see the findings there in the report. I've also provided an update on the lead partner role in terms of the coordination of strategic planning, and can confirm that a permanent team to support, a programme team to support the transformation of Living Life Well has been appointed to, and the programme manager commenced on the 3rd of October. And the team will bring additional in-house capacity and dedicated resource to this work. And the review of governance structures has begun, and the next steps include finalising a streamlined structure and prioritisation of the current work streams and a terms of reference for the programme board, and a team building and priority setting event is taking place on Friday for that very purpose. So and the other main area that this report covers is an update on the work of the Independent Oversight and Assurance Group. You'll know that the Listen, Learn, Change Action Plan was published in August 2020, and the Independent Oversight Assurance Group was established in October 21 and appointed by Scottish ministers. They will complete their work by, I think, mid-November, reporting to Scottish ministers, and the an update in terms of progress against the 49 recommendations for Tayside was provided to the Independent Oversight Group by the 7th of October. And that has been received, and there's further as we await their final report in the middle of November. So in terms of this report, I'm asking the IJB to note the contents of the report and authorise me to continue to engage with NHS Tayside executive directors and the other chief officers to consolidate the leadership arrangements, refine the governance structures and living life well, and bring forward a report to the IJB for approval by the end of March 2023. And also seeking a further report on the implications of the report of the Independent Oversight and Assurance Group and the response by Scottish ministers to our next meeting in December, and also to bring forward detailed proposals around the decision about dedicated provision or single site provision in Tayside for inpatient mental health services by the end of March 2023. And in accordance with the priorities set out by the Independent Oversight and Assurance Group. Thank you.
Okay, I can now take questions. Thank you for that very full update and for the paper as well. I can now take questions. Councillor Illingworth.
Thank you, Chair. The report details the number of delayed discharges in learning disability inpatient services, and it seems like these services more or less been brought to a halt by because you've got 25 spaces and 40 of them are caused by you being occupied by delayed discharges. But under the general adult psychiatry, we're told that there are 13 patients not experiencing delayed discharge, out of how many overall general adult psychiatry spaces are there? So it's really to get a feel of the impact it's having on general adult psychiatry. Roughly, doesn't have to be an exact figure.
Sorry, I missed the end of the question, if I'm being honest. Is it delays in adult psychiatry as opposed to learning disabilities? I'm not 100% sure, but I can. No. It's around about the 20 mark, I would say, across Tayside. We have 5 delays in Perth and Kinross currently.
So is it fair to say that delayed discharges are having a significant impact on the delivery of care for some very vulnerable people?
I think it's fair to say that the delayed discharges are having an impact. And I know from an analysis of the reasons behind those delayed discharge, because this is very much about individual circumstances, but the themes associated with that, one of the key themes is about lack of supported accommodation. And that would be something that we need to pick up in the improvement work that we need to take forward, because that will be supported accommodation in terms of where those people are resident, and that's why this coordination is required. And although we have the lead partner role, we really need to engage the local authorities and others around the development of that provision, and new models around that if possible.
I'm going to take question first from Sarah Dickey and then from Councillor Sheila McCall. Thank you.
Thank you, Chair, and thank you, Chief Officer, for your report today. My comment is really that I welcome the leadership arrangements that you've described and the ongoing engagement. However, I've just got a couple of questions for clarification, please. The first one is that the report indicates that this is a current position in regard to all of mental health services, but if that were the case, I'm not seeing community related services, addictions, etc. The paper seems to have a focus on the inpatients, general adult psychiatry and learning disabilities service. And my second question for clarification,
I was
please.
going to ask, Sarah, do you want that first question to be answered first, and then we'll move on to your second question?
Okay, thank you, Chair.
Thank you very much, Sarah. And I know that when I brought the update to our last meeting in August, indicated that this was a work in progress, and we needed to get the shape and content of this report provided in a way that allows the IJB to take forward its responsibilities here. So in terms of that, the refining the governance arrangements and the reporting arrangements, we need to be very clear about where is the responsibility and where is the accountability for a wide range of services. So if we think about community mental health services, there will be local strategies in each of the local authority areas being led by the IJBs in each of those areas. So it's quite a complex picture to put together, but I think we need to be clear about making sure that we have the content right, and it's not there yet. So it's a work in progress still.
Thank you, Jackie. It's just, like I say, ensuring synergy with the title of the purpose of the report with then the content of the report, just so that the reader's clear what services within mental health provision we're actually referring to. Thank you. My second question was in regard to the element of 2.2.9 in respect to workforce, and the paper indicates that there's a deficit of 50% in the registered nursing workforce, and I just wondered if I may clarify, please, is this in relation to all of general adult psychiatry areas, or just the two that's indicated in the table directly above? Thank you.
My understanding, Sarah, is that that relates to just a few areas, but there's obviously a challenge across general adult psychiatry, but the two areas are those where that are highlighted in the report. So I think those are highlighted in this way, but I'm receiving this information directly from the people who are responsible for the quality and operational delivery of those mental health services. So I can't provide any more detail other than that at this point. Thanks.
Thank you, Jackie.
Okay, I'll take Sheila McCall and followed by Sandra Auld.
Thank you, Chair. Sandra has more or less asked my first question, but I just want to reiterate that the need for inclusion of outpatient services arrangements, and particularly their influence on the inpatient services demand. It was me that raised it at the last meeting, and I did get a commitment from the Chief Officer that it would be included in future reports. So I'm wondering if it's just possible to even put in a placeholder in the report to say that this is being worked on, so we're not silent on it. Because I think, particularly for people with learning disabilities, adequate outpatient services will contribute, I feel, to a reduction in the need of perhaps acute inpatient services in the first instance. And so I think really the report needs to reflect that is a work in progress somehow, because right now the report is completely silent on that. So I just wondered what the Chief Officer might think about that idea.
Thank you for that suggestion, Councillor McCall. I'm aware that the IJB will be receiving an update on our mental health strategy, which I think is in the forward planner for December. So that will be coming forward. So yeah, and perhaps I should have acknowledged that in the paper. So thanks for that advice. Thank you.
Okay, I think it's important. We have a lot of community stakeholders attend this meeting as well, and the community mental health provision is often varied, and I think it's really important that that is acknowledged. I have a second question, Chair, if I may.
Proceed.
Thank you. My second question is in section 2.4, where you reference that the Learning Disability Assessment Unit is particularly challenging, but there are instances where vulnerable patients are requiring inpatient assessment or they're being admitted to the General Adult Psychology Service. I'm just wondering if we have any information on two things. One, how long the stays in General Adult Psychology, or sorry, psychiatry is, what's the average length of stay? And B, if there are any specialists that can attend there to support patients who are admitted into that ward, into that unit, because I think communication with people with a learning disability and understanding can be challenging. And I can only imagine it being far more complex if they're in an inappropriate setting.
Chief Officer.
Yeah, thank you very much, Councillor McCall. In terms of the length of stay, I don't have specifics for you, but I know that in terms of the Learning Disability Assessment Unit, by its very nature, these are shorter stays, and it's quite different to the position that's being demonstrated in Strathmartin, for example. But I can get that information for you and pass that on if that's of interest to you, and seek information about the in-reach into the Learning Disability Assessment Unit in terms of that specialist support. So I can get that information for you. Thanks.
Yeah, that would be helpful. Thank you. But I also think in terms of this report, if it's just isolated cases, then it's a shorter or easier, isn't perhaps the right word, but it's perhaps a more manageable target to resolve. But if it's a persistent occurrence, then, and it's really that definition that I'm trying to understand. If there's something that's happened repeatedly, in which case then it helps us certainly on the board, I think, understand the magnitude of the task facing the Learning Disability Unit and what needs to be done to correct that. Thank you.
Thank you. Thank you, Sheila, and your points well made, and we'll try and reflect that in the next report. Sandra Auld.
Thank you very much, Chair. Just a couple of points I wanted to ask about. I noted when reading the Mental Welfare Commission reports that they require a response within 3 months. And I wondered if it were possible for those responses to be shared with the IJB, please. Just so that we can be kept appraised of the information that is sort of flowing externally.
I don't think that's an unreasonable request, Sandra, because that information should be in the public domain. So I'm happy to share that going forward. I think it would certainly be something that is of interest to NHS Tayside and their care and clinical governance arrangements, but happy to share that.
Yeah, thank you. And my second question is around and it's directed to Jackie. You mentioned in the very good overview you gave of anticipated developments around Carsview, that sort of progress would hope to be made around that by March of this year. I wondered if it were possible at this stage to give any insight into the form that those you're hoping those developments might take.
Thanks, Sandra. The intention is to bring bring forward those proposals. So at this stage, the shape and format of that has not yet been determined. So the work is still to be done. And the reason for seeking a recommendation to bring that forward is actually to bring a bit of pace around that. So I don't have the detail that you're looking for at this point in time, but that's what we're hoping to bring forward in by March, and certainly some direction of travel there.
Okay, thank you. And just finally, just along with councillor that just spoke, I think reading the learning disability paper, there were a number of points within it that were kind of concern around issues like record keeping and residents being locked in their rooms and no one really being sure did they have a key and why that was. And so I guess the concern and the need for a sort of ongoing detail around issues like that, and on top of that, staffing levels remains at kind of at the forefront of everyone's mind, I think.
I'm happy to have that just as a statement, unless Jackie wants to elaborate any further. Thank you, Sandra.
Thank you.
I think in terms of the update to NHS Teesside Board tomorrow, I will indicate that this report has been considered by the Integrated Joint Board, give an update on the recommendations that are approved here, and can pass on those comments, because the operational responsibility for delivery rests with NHS Teesside in relation to the quality of provision there, but I'm happy to pass on your comments.
Thank you.
Councillor Stewart.
Thank you, Chair. Perhaps just following on a little from a couple of the questions that Mrs. Auld asked there in relation to and the responses given in relation to care quality. With respect to 2.13 of the report and the first bullet point there regarding new reporting arrangements to take account of responsibilities in revised integration schemes, would it be just to clarify that will include reporting on matters such as clinical and care governance to this IJB, given that we have operational oversight of the delivery of the mental health services? Thank you.
Yes, that's correct. That's why it's taking account of the integration schemes and the responsibilities of the Perth and Kinross Integrated Joint Board. Yeah.
Thank you.
I have no more questions that I can see. Mr. Pepper's already read out the recommendations, and I don't propose to go through them all again. Are we content with the recommendations within this report? Thank you. That now takes us on to Primary Care Strategic Delivery Plan, and this is the report by the Associate Medical Director.
Thank you, Chair. I'm going to introduce this, which, just to emphasise, this is a draft report that's been brought before consultation and further input, and my colleague Dr. Evelyn Devine is going to describe the report. But I felt it would be helpful as an introduction just to go over a little bit about where primary care is in Perth and Kinross, Tayside and Scotland at the moment. Do we have the slides for the screen? Slides were sent in. Val Aitken has them.
I did hear that. I just wanted to check that whether that's what I wanted. I had meant to take a comfort break after this item, but how long, depends how long this is going to be. 5 minutes? In that case, we'll take a few minutes comfort break, then we'll come back. Thank you very much. Okay then, I think we've had a short comfort break. I'd now like to come back to the paper. We've got the slides up. Thank you very much indeed.
Thank you, Chair. I'm Dr. Dougal, I'm Associate Medical Director for the partnership. Audrey, do we have the slides now? Okay, fine. Thank you. Thank you. Okay, can we move on to the first slide? So I want to just give a short introduction about where general practice is from my understanding in Perth and Kinross and Tayside at the moment. Can we have the next slide, please? Okay, so very quickly, this is going to take 5 or 10 minutes. I'm going to hand over to Evelyn Devine, who's going to describe the draft development plan. So in Tayside, there are a number of general practices. You can see 23 in Perth and Kinross, 23 in Dundee, and 16 in Angus. If you could move to the next slide, please. Perth and Kinross being quite a rural area. You can see on the left, that's the distribution of the rural ones. And just for your information, particularly given the topic coming up later in branch surgeries, where you see the lines, those are branch surgeries. So we have 5 in Tayside, in Perth and Kinross, 3 in the rural practices and 2 feeding out from the city. I think the other thing to note with regards to the development plan is just the congregation or the cluster of the city centre practices. There's 8 practices. They're all within a 450 metre radius of each other, and certainly part of our strategic discussions that we will be having is how we better serve the growing populations both to the east and to the west, in the Bridgeverne Abernethy area, and also to the left in the west to the expanding populations between Perth and Methven. Next slide, please. So I think it's also helpful for you to understand what a contractor status is for a general practice. So we don't employ the GPs. GPs are independent contractors, and that was established when the NHS started in 1948. They're not directly employed, and therefore they're in a fairly unique position. Although they derive the vast majority of their income from the NHS work, they remain employed, and therefore, as I say, we have a different a relationship than we would have with employees. Next slide, please. So there are 3 different types of contract. I'm just going to briefly mention this. The GMS one, which is one we talk about, which is a standard nationally negotiated contract, and that is you're contracted for a geographical area, so a specific geographical area, and you're contracted to provide essential medical services. And over and above that, there are enhanced services which are negotiated and delivered nationally and locally. There are also board-run practice contracts, which are these 2C ones, and I'll mention that in a wee bit later. And the 17C one, I would ignore that. We've got one in Tayside, but they're just sort of specially negotiated for depending on the circumstances. But the majority would be GMS or 2C. Next slide, please. In terms of the contract itself, that's held by the NHS Tayside. So it's NHS Tayside board who decide who holds a contract and has those contract negotiations. They're also responsible for the professional advisory function for general practice. So that's at the top there in the slide. To the left, you'll see we have an arrangement, a hosting arrangement, which has been evolved in the most recent iteration of the integration scheme. It used to just say primary care, but now it says that there's a lead partner for the strategic coordination in relation to primary care services. So it's been unclear in the past, and I'm not sure it's got clarity just yet. So that's the hosting arrangement with Angus, NHS Tayside Board of a Row, and in Perth and Kinross, the budgets devolved for the new GP 2018 contract come to the IJB here. And so we then employ quite a significant number of staff who now work within practices, so physiotherapists, pharmacists, mental health support workers, nurses who work in the community, as well as our previous health visitors, district nurses, etc. So more of the primary care team is now within the partnership employment. Next slide, please. I just throw the slide in. This is out of date now, but when there was a review, an independent review of adult social care, one of the recommendations was that perhaps the contract should sit with the local IGBs, because that's who would probably best know our own communities, because it recognised there was a real confusion with all these different responsibilities across the areas that I've described above. However, that recommendation wasn't taken through to the final report. Next slide, please. So this is just a very quick slide that shows you that the GMS practices in the dark blue and the 2C ones in the light grey there. You see Tayside has more GMS practices than other areas. So places like Forth Valley, Highland, Ayrshire and Arran have got more board run practices than we have. Next slide, please. This slide here just shows you the ones in red are the 2C practices. So these ones that have been run by the health board. When practices start feeling the strain, they often request to close their list. And these are the ones shown in amber here, or orange. So there's a number of closed list practices and 2C practices across Angus and Dundee, but none at the moment in Perth and Kinross. There was a number of years ago when we had the Bridge of Erne practice. It was the partnership's proposal that that a 2C practice should be considered there, but again, because it's a health board that negotiates these contracts, runs these contracts, it was their decision that shouldn't be the case, and the practice closed at that time. Next slide, please. And although we have no 2C practices, because of the historical arrangement, we fund them out of our budget, at least a share of it. Next slide, please. So what's happening in general practice? This is the internal audit. This is the Audit Scotland report from a couple of years ago that basically says list sizes. So the number of patients that are on GP practice lists is increasing. The number of 2C practices, i.e. the ones that are run by NHS boards, is increasing as practices fail. And there's a falling number of general practices across Scotland overall. Next slide. You'll read in the papers of all sorts. You read it online. You can read it in the British Journal of General Practice or in the King's report there on the right-hand side about the pressures on general practice. The volume and complexity of what's done in general practice has increased hugely over the last few years, and we're seeing the population's larger, it's older, it's more diverse, and it's more likely to seek professional help for health concerns. There's also a move to move care closer to home, which means that many activities previously undertaken in secondary care are now done in primary care, but the funding hasn't necessarily followed to do that. And that's making it very difficult for GPs to provide these services. And this is a sort of, the next slide, please. But there's a whole number of pressures that are making primary care less and less sustainable. When I started primary care 25 years ago in Perth and Kinross, it wouldn't be uncommon that I would have heard 100 applicants for some of our jobs, particularly rural jobs from Perth and Kinross, whereas now some of our really, good rural practices are sitting with vacancies for months and months and years. So the picture and the landscape has completely changed from what it was before. Next slide, please. It's partly in recognition of that, the 2018 contract change with a move to try and have less dependency just on GPs. So it used to be that GP was the gatekeeper or was the signposter. And there's now a move to switch that around so that GPs become a destination on that signpost, but they're not the ones who are signposting everybody. So in other words, you phone up the GP practice, it might be that you'd be better to see a pharmacist, a practice pharmacist, to discuss medication issues, or one of our mental health support workers to discuss issues around health and well-being, or to see a physiotherapist who's very skilled and more skilled than many of us GPs in dealing with musculoskeletal issues. And that was the aspiration of the contract. However, we estimate in Perth and Kinross we probably need another 50 to 60% funding in order to fulfil that aspiration. Next slide, please. So to help us better understand what the state of play was across Perth and Kinross practices, we took the initiative last year to do a survey which we adapted from a Welsh framework. Every practice in Perth and Kinross participated. In addition, we had the Newber practice, which provided some cover for some patients around the Abernethy area in Bridgevern. And we've done a second round of it. And the bits that this looks like in terms of resilience, the things it looks at are the number and age of GPs, retirement plans, how many vacancies they've had, what the level of GP cover is, whether it's a training practice, what recruitment problems they may have had, what the resilience is if somebody's off sick, the number of sites, because we know a branch surgery adds extra strain, premises, organisational factors, and also financial stability. Next slide, please. And when we put all these together, this is an anonymised list of practices, the 23 GP practices in P&K plus the Newborough one there. And you'll see that any score above 70 is deemed to be at high risk of unsustainability. So a third of our practices in P&K are thought to be at high risk of unsustainability, a third at medium risk, and the other third seem to be okay just at the moment. Next slide, please. And that's basically the summary there. So 20% of the workforce are aged over 55, 10 to 15% are likely to retire in the next year or two. And this was probably based on a year's data, so some of those are coming through already. 13 practices out of 23 have experienced difficulties recruiting GPs. And at the time of the survey, 7 practices had 1 or more vacancies. So it's a really stretched position right across the country, and we're no different in Perth and Kinross. We've been fortunate so far that we've managed to sustain all of our practices. We've had a couple of brief list closures, but at the moment we've got no closed lists. But we want to move beyond that, and that's part of why we're bringing forward a strategic delivery plan for discussion, which I'll hand over to Evelyn to guide you.
Okay, thank you very much, Dr. Dougal. I can call you doctor, you just can't call me doctor. So you have today the Primary Care Strategic Delivery Plan for 23 to 26. And the purpose of the report in front of you today is to acknowledge that this is a draft for Primary Care Strategic Delivery Plan, and to really request a period of consultation with our key stakeholders, inclusive of Angus IJB as the lead partner for primary care. And for that to be completed by the 31st of March. So that gives us quite a significant amount of time to do some really robust engagement. But also I think it's important to note, and it has been mentioned already in the previous presentation, that we need time to create and support a 3-year financial framework for the strategic delivery plan. It is a challenging plan. And it certainly has its financial challenges as we try and move forward with the full implementation of the GMS contract that was started to be implemented in 2018. We're also challenged just currently around primary care mental health services. Although we have some specialist mental health nurses in place, we had been asked by Scottish Government to put forward a much more robust proposal around mental health and primary care, and to date, although we have written this into the paper, we're still awaiting the outcome of funding for that. So I just wanted to sort of flag that up first of all. So in relation to the background of the report, I think the report is based mainly on the reform in primary care through the implementation of the 2018 GMS contract. This required significant service redesign within the HSCP, whilst expanding community services to support the GMS contract in relation to the multidisciplinary workforce. However, this came with significant investment in order to be able to support that, so that has been helpful. I just wanted to sort of clarify what the Primary Care Investment Fund has and is working towards in terms of its implementation. And I think we've mentioned some of this already. So we have the sort of 6 key priority areas for the fund. The Primary Care Investment Fund are pharmacotherapy, MSK, first point of contact, social prescribing, urgent care, and primary care mental health services. How can I forget? There is another aim to the strategic priorities, and that was in relation to the development of community care and treatment services, of which we've established a significant number across Perth and Kinross. And in relation to vaccination, which is another part of the contract, that has been taken forward by NHS Tayside as we speak. So you will see within the Primary Care Strategic Delivery Plan, there has been an agreement of 3 strategic priorities. One is based on outcomes for people. The other is outcomes for the workforce and sustainability, which we've heard quite a lot about just now, and then outcomes for the system. So in relation to outcomes for people, we have put forward that patients should experience an enhanced and service and feel more informed and empowered. And we really want to push forward with right care, right place, right time. And that involves who in the multidisciplinary team needs to see the patient at first point of contact. So to do this, we believe that we need to have further engagement with our localities and communities and on the new approaches that are currently being delivered. And taking into consideration rurality in Perth and Kinross, because obviously that's quite important. We want to support and promote early intervention and prevention, and certainly to work with our third sector and public health around what the art of the possible is. Again, I've talked about access to primary care, mental health, and I think that's really important for us in Perth and Kinross, and we have had in the David Strang report, that was a big element of access to mental health services as close to the patient as possible. And once again, we have a big quality prescribing programme on the go, and we'd want to maintain and do more of that in terms of supporting people. So the next strategic outcome that we have put forward in the paper is that of workforce, which again we've heard a lot about today. So we have proposed and developed and achieved funding for a primary care resilience team in order to support our practices that are tipping into the red that we've seen earlier in terms of the heat map. However, we have struggled slightly with resourcing this team, and we probably just need to take a step back and review that and see what else is the art of the possible in terms of supporting practices that are beginning to fail, and that may be used more of our advanced nurse practitioners within that. Again, onto the workforce, we want to look at the interface issues in and around primary care and secondary care in particular, and we've started some good conversations around looking at improvement work across both sectors, and that would include our GP practices and PRI, for example. And I think this strategic delivery plan doesn't sit in isolation of the older people strategic delivery plan or the mental health strategy, because we need to, as the HSCP, look at our workforce as a whole and how we better integrate our workforce around primary care to support. So again, we're acknowledging we need better integrated working, better planning, more involvement of service users and access to good information, which we're starting to work on at the minute. And the other thing that within the workforce that we really need to push, and this is in my slides later on, but it is about building on that urgent care home visiting service for general practice to support them, and that will include our integrated teams across our localities and our ANPs to support that. So in relation to the third outcome, and a very important outcome is outcomes for the system and optimising our investment in and around our primary care infrastructure. In order to do this, we need to really be supporting NHS Tayside, because they are really the responsible parent body for supporting, for example, a premises strategy for primary care, and we need to work with Angus as the lead partner around that. We have mentioned in the strategy, you know, addressing the Western Edge expansion. You know, we're also considering the Eastern Edge expansion, as Hamish has already alluded to. And we also need to look at premises per se, and we're working with Perth and Kinross Council in relation to the one public estate to see how we can use our premises more efficiently. We do have an issue with our care and treatment services in Perth City, and we are continuing to look at alternative accommodation there. So over and above that, you know, just really pushing forward digital solutions, infrastructure, GP, IT systems, etc. So in conclusion, the primary care strategic delivery plan needs to build on the progress that we've already made. It needs to develop further key areas around engagement, the primary care improvement programme itself, GP sustainability, our premises strategy, and development of skills and access to primary care to support the strategic direction. So with that, happy to take comments. And do you want me to note the recommendations again?
Thank you. Thank you.
Okay, so in terms of the recommendations, we would like to recommend that the IGB note the development of the draft primary care strategic delivery plan, approve a period of consultation and engagement with key stakeholders, inclusive of Angus IGB as the lead partner for primary care services, to be concluded by the 31st of March 2023, and to note the establishment of a 3-year financial framework which will be developed by the 31st of March 2023. Thank you.
Thank you very much indeed. There's a lot of interest in this subject because obviously, particularly in an area such as Perth and Kinross, rural services in particular, it's a mainstay for many communities. There will be a lot of questions, I'm sure. Thank you both for that presentation, and also we'll ensure that the slides are circulated after the meeting around the board. Thank you very much. I'm going to take some questions now. Sally.
I've just got, first of all, I would like to thank you. I think you've really represented primary care and the challenges really well from my perspective as a GP. I just had a couple of quick queries. I was really pleased to hear that this is a draft and going to consultation. I'm sure you're aware of how important I feel that it is that you consult with frontline staff, patients from a various of backgrounds. So I was really pleased to hear that. I just had a couple of quick queries. This is just really from something that's mentioned in the report, and it's really for clarification about access to full access to services as compared to access to services, and exactly what that means, because I was unsure exactly what that meant. It's on the progress to date. Yeah. Because we've got a conflict here between full access to contact physio, but I only have access to ear syringing.
I think Sally would like to bring in Lisa Milligan. I think she's online, and Lisa would be able to give us the interpretation of this, because this will not be our template. This will be a Scottish Government template.
Thank you, to get that.
Thanks, Lisa.
In line. Hello. Yes, the interpretation of it is in line with what we are reporting back to government with regards to the PSIP programme and where we sit within each of the 6 services that we are directly involved with. So for some of the practices, they don't have full access to these services as yet, but that's part of what we're trying to develop through our financial framework and the performance management.
I'm just wondering, because that doesn't give me the definition as such, which is the bit that I'm trying to get my head round. Is that full access? What does full access mean? That's the bit that I'm struggling a little bit with. Thanks, Lisa.
Lisa?
That's out the 23 Lisa? Practices. Yes. Oh. Apologies. Yes, out of the 23 practices, not all 23 practices currently have access to some of the services.
Yeah, I might just come back. I think there's two different definitions here. Full access is defined by some of this as having all practices having access to something. I think what you and I and others, and what the aspiration of the plan in recognition of full support for general practice as aspired to by the 2018 GP contract would be, what would a full access, so every patient phoned up and wanted a first contact physio appointment, they had one available. That's probably what you take by full access. And that was why I was alluding to the fact, in order for us to do that, we would need 50 to 60% higher budget than we've currently been allocated from Scottish Government in order to do that. So either we need to wait for that funding to come, work more effectively and efficiently, or find additional new resource if we see that as a priority.
It was just a third question that I just had, which is just, again, I really applaud your the priorities about an integrated and coordinated workforce, and obviously we talked about multidisciplinary teams. Do you think that's manageable within the funding that we have? We've noticed that a lot of, because of workforce, are going to hubs. So, for example, I've got my physio in the practice, but they're seeing different patients from different practices. So I think that relationship that we have with our multidisciplinary teams is difficult to maintain while we're in hub services. But I think it's difficult to maintain when we're struggling with the funding and gaining staff as well.
I think I would agree with the principle of that. It is very difficult without the full funding of the contract to be able to do that. However, I think we all need to consider how we work together, and I think there's definitely an ability to rethink where we're at with the integration of teams and how accessible they are. We know we've got a bit more work to do as a HSCP, integrating our teams, and that's what we're working on currently. So I think as long as we engage GPs in that, I think that will be the important thing.
I'm going to bring in Jane Smith here to respond to some of those issues around about money.
Thank you, Chair. Yeah, it's a useful opportunity for me just to consider the financial implications of the draft plan. And one of the reasons that we don't have a financial framework in it at this point is that it is really, really important in the current financial climate that we get a really strong assessment of those financial implications. And I think, as everybody knows, the financial landscape at the moment in relation to NHS boards across Scotland, local authorities across Scotland, and in relation to the Scottish Government themselves, there may be some difficult decisions ahead for the IJB when the full plan comes forward, which is fully costed in relation to achievement of ambition, should there be no additional resources forthcoming from either Scottish Government or ultimately NHS side, and that is going to be a tricky path for the IJB to navigate, given I'm sure their wish to deliver on the ambition set out in this plan.
Okay, thank you. I've got a whole list in front of me here, then I'll come to you both. I'm going to take Sandra Auld first and then Sarah Dickey.
Thank you very much, Chair. So I have a couple of questions which I'm asking on behalf of my colleague Ian McCartney, who unfortunately has been able to, he's able to listen and see proceedings, but he's not able to contribute. So one of the questions regarding property within and premises within Perth and Kinross is Ian's understanding on the high levels of asbestos cladding in a significant proportion, up to 75% of NHS facilities in Tayside, and just how that might be taken forward and how that's being dealt with. And I also have a follow-on question related to Jane's last comment regarding budgets, and that question is relating to the COVID recovery funds that we understand that Scottish Government has clawed back. So it's just some information regarding exactly what is happening to those funds. So two very separate questions.
Thanks very much, Sandra, for those questions, and thank you for Ian for posing these. In terms of the asbestos information, I don't think we're cited on that information in this group here, but we will try to respond to that, given what you've said. Hamish, do you want to respond to that first, and then we'll move on to the question for Jane?
Yeah, just in relation to premises for general practice, and I appreciate the wider NDT work in other practices, but there are only two premises in Perth and Kinross which are Health Board owned. One is Aelith and the other one is Drumheart Health Centre, which in fact is not Health Board owned, it's NHS, is PKC owned and leased by NHS Tayside. And as far as I know, Aelith is a more modern building and wouldn't have any asbestos.
Right, we'll see if there's any way we can gather any more information on that as part of the consultation, in fact, if that's an issue. So the second part of the question was relating to, I think, question for Jane. Jane, do you want to pick that up?
Thank you, Chair, and thank you, Sandra, for the question. The issue of the potential clawback of COVID reserves was raised by external audit at our recent Audit and Performance Committee, and subsequent to that there have been discussions nationally. The Scottish Government have, as I understand it, taken legal advice, and that at the National CFO's meeting yesterday, the CFOs have asked that advice now be shared, but that advice would indicate that legally the Scottish Government are able to claw back the reserves. I'm hoping to get a copy of that advice shortly, but that wouldn't negate the need for the IJB still to approve the passback on the basis of seeing that advice, and the intention would be to bring a paper forward to the IJB in December to seek approval.
Okay, thank you. That takes me now to Sarah Dickey and then to Donald McPherson, and then I'll take Councillor McCall.
Thank you very much, Chair, and thank you to Evelyn and Hamish for their presentation. Just a couple of comments, if I may, and I really welcome the opportunity for this to be in draft and for further consultation. My observations of the strategy to date would be that I would wish to see more synergy with the work with care home sector, given the healthcare framework for care homes that was published earlier this year, and also in respect to the GP practice nurses in terms of their management of long-term conditions in our communities. And obviously, notwithstanding that, we have a new senior nursing post since August, Maureen Fagan, who obviously will be a key point of contact in regard to getting views from the GP practice nurses. The final comment is in regard to inclusion of palliation and end-of-life care, perhaps being a measure in the framework that's being proposed in regard to the care of a person at end of life in their own homes. And other than that, I don't think I've got anything else, but thank you very much. Really welcome the opportunity to comment on a draft. Thanks.
Thank you, Sarah, for that. I think these are pretty valid points in terms of, and I suppose that's why I was referring to, you can't really see one strategy, you know, without looking at the others, because obviously the care home work is within the STP for older people services, and palliation as well. But I take the point, and I think we can cross-reference them. And I think that Maureen has obviously been working with the primary care team extensively as well. So, but absolutely take those points on board. Thank you.
Thanks, Evelyn. That's good to know. Thanks.
Okay, that takes us to Donald and then Sheila McCall, and then I'll take Colin.
Thanks very much, Chair, and thank you to you both for bringing this strategic delivery plan forward in draft form. I mean, I think it's a very, very good document, recognising it is still work in progress, and clearly a lot of thought has gone into it already. My question was really just around the role of the lead partner, Angus IJB, in all of this. I think Hamish touched on that as being strategic coordination in relation to primary care services. And my question was, are we clear enough what that actually means in practical purposes, and where the dividing line sits between our responsibility and Angus IJB's responsibility? Because I think it's important, as you do this piece of work, that we know where those boundaries are. So I'm just, I have asked in another place, would it be possible to get some sort of a schematic to show the difference between the two roles? And I think some form of explanation would certainly be helpful for me, if for no one else.
Chief Officer will respond.
Thank you very much, Donald. I think you raised some really important questions there, and it would be helpful to note that we've provided a copy of this draft report to Angus, Chief Officer, for consideration as we work through the implications of the lead partner role there. And I think your questions around clarity around what that means in practical terms, because I wrote what you said down word for word, and in terms of the boundaries and responsibilities. I think that's still something that we're working through. I need to probably work. This would be a very helpful example in terms of where will this report go from here in terms of the consultation across the whole of Tayside and its journey there. So we will work that through together. And I think there's a nod to the event in the Mental Health Services update report, that along with Margaret Dunning as the Board Secretary for NHS Tayside Board, that it's likely that we need an event that will bring together members of the IJBs and NHS Tayside Board to actually work this through in practicalities together through a workshop, for example. I suspect now that we're in the end of at the end of October that would be into the new year, but I think that's certainly something that would help work that through in practical terms. But right now we're continuing to discuss this with our Chief Officer in Angus in terms of their lead partner role. Thanks.
Hamish wants to come in here as well.
Yeah, I would agree that I think it still is a confused picture, and clarity would be helpful. I think it's worth recognising that when the IGBs came into existence, general practice was quite different, and that we didn't have a new GP contract with funding devolved directly to the IGBs. So there was a much more of a central control, whereas now we've got a very large workforce which are working locally, and they're integrating with our existing teams, and therefore the role of the whole hosting, I think, is still a valid one, and maybe there's a question as to whether it's the best model, and whether because it's a locally run service integrated with other services, whether it would be better to be locally run.
Thank you very much indeed. We could have some visibility from the lead chief officer when we come to the final iteration of this. I think that presence and visibility is really important, because it feels still very amorphous at the moment. But you've had to take a significant lead role with mental health, for example, and I think I'd like to see that quid pro quo coming from other lead roles, and I would certainly seek that. That takes me to Councillor McCall, and then Colin, followed by Beth, and then David.
Thank you, Chair, and thank you very much for this report. It makes very interesting reading. I think my main question is around priority 3 and 3.1 in particular. actually have several aspects to this question, so I'll just plough on with them because they're all sort of interrelated. One of the things in this section is that we in recent years have completely lost a GP practice in Bridge of Erne, with a number of patients transferring from there to Perth surgeries, which has put then additional strain on those. So it's a little bit disappointing not to have included in 3.1 areas where GP surgeries have been withdrawn for whatever reason. And I don't want to preempt the next paper, but it looks like there's going to be a satellite surgery also been recommended for closure. And that leaves, it takes away from our aspiration, I think, further down at 5.1, I think it is, to, or 4.3 rather, is to make sure that we have care service at the heart of the community. So I think it's disappointing that's not there, and I'd like to understand why not, why that isn't considered. And the other comment or question I have really is on the main paper in terms of the engagement with a public engagement plan. And again, I'd like to think that those areas that have had their surgeries closed and that service withdrawn from the local community would be included in a public engagement plan, because I know people who live in those areas who are finding it extremely onerous to travel. And I suppose my final question is, and again, it's back to 3.1, the need for suitable accommodation for the delivery of effective community care and treatment services. And I think that I would like to understand whether that means a single premises or whether it means a distributed model, particularly when you think about community services such as that we have here in Perth and Kinross, where we have community physio and OT services operating out of Puller House, and we have the district nurse service operating, I think, I'm not quite sure where, out the GP surgery. So is that a single premises we're talking about, or are we looking at a distributed model for premises for these community services to operate from? Well, that makes sense.
Yeah, I'm very happy to respond to the first part. In 3.1, there is an omission. It should say Perth Western and Eastern expansions. So that's a pretty grave omission, but let me reassure everybody that in all the conversations we have about the strategic document and the conversations we've had with, general practices, the issue around Perth and Kinross, around Perth City, and particularly the Bridge of Erne closure and the expansion to the west as well, and the lack of any Perth and Kinross or Tayside practice coverage for the Abernethy area is absolutely at the heart of our conversations. It would be our aspiration that we look to developing a new GP practice both to the east and the west of Perth City. And we have had early conversations with general practices within Perth City about possibly migrating one east and one west. That is a massive task. Contractually, organisationally, in all sorts of ways, both in terms of delivering premises and organising the switchover of moving services and contracts and patients. If we opened up a new practice one day, that practice would have no patients until patients elected to move to that, because you can't move patients from an open practice to a new practice. Even if they change their practice boundary, that's not allowed. So I share your disappointment that Bridge of Erne closed a number of years ago, but absolutely reassure that part of our strategic priority is to absolutely explore how we can better provide services both to the east and to the west of Perth City. I'll maybe let Evelyn pick up the next two.
So in terms of public engagement plan, Councillor McCall, yes is the answer. We plan to engage on primary care services by locality and sub-locality. We've already begun engaging around our older people services, and we've plans for November for Highland Perthshire to start commencing there. So yeah, the simple answer is yes. And in relation to community care and treatment, we are needing to look for a single site really for the community care and treatment service. It is a big service. It has a big throughput of patients on a weekly basis, and we do need to think about the throughput there. But again, in engaging in the one public estate with our Perth and Kinross Council colleagues, you know, we are looking at what accommodation is available, what makes sense in terms of putting teams together, you know, to make that more efficient. So that would be our ambition, is that we have accommodation fit for purpose where we can integrate teams, you know, at that single point of contact. So yes, a bit of everything really.
Thank you. I have a couple of related follow-ups, if I may, Chair.
If you could be very brief, because I
I
still have
will
a
be-
number of people who've not had an
Thank you. I will be very
opportunity.
brief. In terms of the eastern and western expansion, that's very welcome news. But I'm also concerned about Highland Perthshire, because there is, as I said, I don't want to preempt the following paper, but there is a proposal to reduce services, not reduce services, but to consolidate services in one area, leaving a large geographical spread. So I would like to think that that might be also included in the in your considerations, because rurality is a big issue for Perth and Kinross. And regarding to the community care and treatment services, I understand the need for premises, but I also understand that in particularly areas of high deprivation, people like to have services where they live. And you know, there's often issues around transport and logistics, etc. So I think it might be worthwhile considering how you can have a central point with maybe a distributed hub, a hub with a distributed service delivery. You know, we have a lot of public buildings, and we should be able to think about how we use them, but we also have a lot of community assets. So it's just to maybe think about a wee bit more laterally rather than a single point of contact for people. Thank you. Thank you, Bob, Chair.
That's okay. I think the consultation is already starting from what I can hear. Do you want to pick up this and then we'll move on to the next question?
I just think in relation to community care and treatment services, we have tried a distributed model. We did that at the outset and it just didn't, it was really difficult to run actually in terms of, you know, attaching it to GP practices, and the premises weren't suitable either for that distributed model. And I'm talking in Perth City because obviously we have community care and treatment services all over Perth and Kinross, but people can also choose. So if you work in Perth, in Perth City and you live in Highland, you can go to the community care and treatment service in Perth City. You don't have to go to your local one. So there is a way to actually be able to do that. But I do appreciate that some of the transport issues, and when we're looking to relocate, we need to be mindful of transport issues for people and have it on a direct bus route or whatever. So.
Okay, that now takes me to Councillor Stewart and then Beth and David.
Thanks, Chair. I do have a few questions. I'll try and ask them quick fire manner, and some of them are similar to Councillor McCall's that have just gone before. In terms of the recommendations, the second one is to approve a period of consultation and engagement to be concluded by the 31st of March. I just wondered whether that was concluding the consultation or a report back to the IJB.
Who wants to pick up on that?
I think we could include a report back to the IJB, yes.
Thanks very much. And I wondered whether also we could include primary, there's mention of the primary care strategic delivery group, and I think elsewhere as well there was mention of the primary care board, and whether we could get back details of who's on those and what the terms of reference are.
Collins, a nodding of head to that.
Thank you. And in terms of who the consultation is going to be with, specifically the period of consultation planned is engaging with primary care partners, including Angus SCP, Dundee GP subcommittee and Perth and Kinross GPs and cluster quality leads, with further direction to be taken from Angus as the lead partner for primary care on a public engagement plan. I just wanted to be sure that we are actually going to go and talk to service users, you know, for example, the people of the who have used the GP surgeries that are being disadvantaged, for example, in Bridge of Earth. There's nodding again there, so I'll take that as a yes. Thank you. I had the same concern as Councillor McCall that the Bridge of Erne, re-establishment of a practice in Bridge of Erne hadn't been included in 3.1. If Dr. Dougal says that Eastern Perth Eastern expansion covers Bridge of Erne, and that's to be included. I'll take that as he says, but it is just to point out that 37 months ago, this IJB did give instruction for the re-establishment of primary care in Bridge of Erne as rapidly as possible following the closure. It was disappointing to hear that the 2C option wasn't explored and taken up by NHS Teesside. And just for the newer members of the board, for clarity, the reference that Dr. Dougal made to Perth and Kinross contributing approximately 1/3 of the 2C costs means that Perth and Kinross Health and Social Care Partnership is contributing to those 2C practices, 2 of them each in Angus and Dundee, but we're not getting any reciprocal arrangement in terms of the establishment of or re-establishment of the Bridge of Erne practice. The last question I want. It was just for information, but if somebody wants to confirm it, that's fine.
I think on that particular point, Councillor Stewart, it might be helpful to bring back some information on that to a further meeting, because I'm aware that in my discussions with the Chief Officer in Angus, that may not be the approach that's taken this year in terms of sharing the costs associated with the 2C practices. So that would be something positive to note if I can bring back confirmation of that when that's the case.
That would be excellent. And my last question, I think, is building on maybe the question or the questions that Councillor McCall had about things like the community care and treatment centres, vaccinations and so on. I mean, I have in my ward, in Strathmore ward, a GP surgery where people can't any longer go and get things like blood tests done, wounds dressed. They have to actually come from Scone across Perth, I think, to the Taymount surgery or maybe to a community care and treatment centre in Perth, which, you know, runs counter to all of the both the Scottish Government and the Perth and Kinross Council objectives of delivering 20-minute neighbourhoods, of delivering you know, locally sustainable services, of delivering you know, lower traffic volumes, and so I just wonder whether Dr. Dougal or Mrs. Devine or anybody else thinks that actually the GMS contract has been a success in delivering for local residents. It might have worked from a system point of view, but does it work for patients?
I suppose the consultation doesn't wholly cover that, but I think it's a fair question, actually. I think that kind of reflects some of the range of questions we've had around the room today, and it'd be useful, certainly if we don't want to respond to it today, but if we could just convey that as part of our written feedback around those very questions. I don't know if Hamish wants to come in.
Yeah, I mean, I think it's a very valid point. I think for some, in some areas, it will have made very little or no difference to individual service users because they just maybe go to a different room in the same building. But we'd certainly want to know of examples of where we can provide more local services where there is a need. But I suppose that one of the words used was about sustainability. So we have limited resource. I've already described that to deliver full services, we feel we need another 50 to 60% of income. And therefore, there will be this tension between how local can we make it if it becomes less efficient. So we know our pharmacotherapy teams, for example, are working from a hub model just because they don't have the physical space and they don't have the manpower, and they think they can do more work effectively, more efficiently, and do more of it from a hub model. So they're centralising. But I absolutely take your point on patient access and patients not being disadvantaged.
Okay, thank you very much indeed. And that takes us to Beth Hamilton and then finally David. Thank you, Beth.
Thank you. 2 quick points. I think the first is I would ask that part of the consultation is part of an education programme. I think it reflects fully this discussion that this is a primary care, this is not GP services. And I think we really need to educate the public on the difference with that. I know I hear on a regular basis through health routes about people being offended that somebody other than the doctor tells them they could go to the mental health nurse, or they could, and this seems to be a theme that people do not understand about the infrastructure that has been developed. So I would beg that as part of this consultation process, when we're out, we should take advantage of educating people about what primary care is. And the other thing that I wanted to highlight is the link with urgent care. I think there's all the issues around turning up at emergency services, etc., care and treatment services, minor injuries. And we're looking at this. I know each strategy is individual, but we talked about Angus, we've talked about our own primary care, but I'd be keen to make sure that we take into account the whole system around emergency services and urgent care. So that was my 2 points. Thank you.
Do you wish to answer any of these, or we'll just note them? Sally, I'm sorry, I've got David in first. Oh, I see, right, sorry.
About the communication thing, and just to reassure that there's a specific meetings around communication that are actually occurring now with CQLs, the clinical lead in the Health and Social Care Partnership, with the comms team from the Health and Social Care Partnership, exactly for these things. We've only just started, so we're getting our heads around it, but these are certainly issues that have already been raised within that group.
Okay, thank you. And finally, David, that's a shame, David. You said you were going to ask a question about this at the very beginning. You've ended up being the last person. So fire away.
Thank you, Chair. Like Councillor Stewart and Councillor McCall, I share, and as a local member for Bridgeverne, I share the concerns about the lack of service in Bridgeverne. There's deep concern in the community about the lack of communication. You've said today that is kind of part of the strategy. What communications can be put in while managing expectations? What communications can we as elected members put out about the possibility of a new health centre in Bridgeverne?
I mean, I would assume that would be integral to the consultation process and the needs assessment, absolutely. But again, I would emphasise that we can take all these views and we can develop a strategy, but ultimately it's for an HST side to enlist a contract and to decide that they want a premises there. But you're hearing, I hope, loud and clear that we as a health social partnership feel that is certainly a strategic direction that we would support and have done even when Bridgeverne was a working practice. We worked very hard to support it. We tried to keep it, we tried to have an ongoing presence there with a medical centre, and we still hold that a strategic objective, I would say.
Yeah, the question I'm asking is for help with the communication to the community, so that they feel, and I would stress the word feel, that nothing is happening, they have no information, and it may be like, swans and they work it away all underneath, but you don't see it on top. So any help that you can offer with communication would be very, very gratefully received.
Yeah, that's right. I'm going to ask Jackie to come in now. I think your point's well made, Councillor. Thank you.
Thank you very much, Councillor Illingworth. I know that Hamish, as in his role, and I have met with representation from the Community Council and had given a commitment to working alongside them in terms of some of their own research that they wanted to carry out. So if there's an issue there in terms of communication, I'm very happy to pick that up following this meeting. Thank you.
Thank you very much indeed. And I'd just like to reiterate, Jackie, I'm assuming that the recommendations will be supported, but could I emphasise that when we come to the final document, that we get a lead presentation? I would prefer to this IJB from the lead chief officer. I think that's critical given the scale of the raft of questions we've had here. And of course, you can address the Perth and Kinross implications, but I would like to see a lead role here. Thank you. Right, I'm going to take the, since we're talking about primary care, I'm going to take the next issue and then we're going to have a break. So who's going to lead on the consultation on Athol medical practice? Jackie.
Thank you very much, Chair. This report informs the Integration Joint Board of an application by the Athol Medical Practice to amend its contract with NHS Tayside. And if approved by NHS Tayside, this change will mean that the practice will provide all of its patient consultations, those consultations that take place outside of the home, at the Pitlochry Medical Centre, and the part-time branch surgery at Blair Athol would close. It's important to note that in doing so and making that change, there would be no withdrawal of services from patients, and the practice is proposing to consolidate its GP consultations on one site, and that patients will continue to receive all of the primary care services that they do now, that they would continue to receive those and that professional support. The Health and Social Care Partnership was notified of the application and asked to support the practice to carry out a consultation with patients on this matter. And the report before you today sets out the detail of how this was carried out and provides evidence of how this was conducted. It is recommended to the Integration Joint Board that an inequalities impact assessment is carried out in advance of the decision by NHS Tayside Board, and that there is further exploration of measures that can mitigate the concerns that are raised in the consultation and the impact of the change, for example, through community transport, a possible community transport initiative. The IJB is asked to note the findings of the consultation and to make comment in advance of the application being considered by NHS Tayside Board. And there are a number of us present at this meeting who've been involved in that, and Lisa Milligan, who's joining online, the Service Manager for Primary Care, who worked with the practice on the consultation, and she's able to provide any detailed information on the consultation itself. Thank you.
Thanks very much, Jackie, and we'll, Lisa will take some questions on this as well, if that's fine. I think it's important to emphasise the last bullet point, which is about providing comment for NHS Tayside, which is what I'm sure we'll have lots of comment, but also just to underline the fact that a full equalities impact assessment is still to be done on this matter. So I'm opening up to questions now.
Thank you, Chair. With regards to the consultation, I understand from a local elected member in Blair Athol that a petition was raised with 107 comments. Could you help me understand why that wasn't included in the consultation? I'm sure there are very good reasons, but I'm happy to understand them.
Who wants to pick up on that question? Evelyn? So
I think the summary of the consultation is within the document here from at the Struan Community Council, but I'm happy to bring Lisa in for the detail on that.
Struan had done that independently, and that wasn't part of the consultation that we were involved with for this particular part of that had been done previously, which was actually before I came into post, so apologies, I don't know the detail. I know that it wasn't shared.
So I didn't quite catch that. You're saying that it wasn't, it took place before the formal consultation was started. Is that the case?
That was last year. The formal consultation for the purpose of this report was between the 11th of August and the 7th of September for this year.
Great, thank you. That's very helpful.
So that consultation prior to the formal consultation, would we still see sight of that as part of the feedback? I think that's quite important if that work's already been done and could be added into the consultation, I would have thought. Although, yeah.
I think as part of the consultation, you'll see in the paper the comments from Blair, Athol and Struan Council in relation to their concerns. And I'm presuming that is part of the survey or consultation they've done. Actually, we have not been party to the outcome of that, but we have the information around the issues that have been flagged up, which are within the paper.
Want to come back?
Yeah, I understand there were also issues with GDPR, and the people who signed the petition hadn't given permission for the names to be revealed. General Data Protection Act, excuse me, and that was one of the reasons.
Yeah, I think it's probably helpful just to make a comment on that, because what you see in the report before you today is a summary and an extract from the submission provided by the Community Council. So one would assume that would have incorporated the results of a petition or any consultation that they would have carried out. But I think what Lisa was saying in her first answer, I think you were cut off just at the beginning there, Lisa. So I think what you were saying was that petition has not been provided to us. This is a portrayal of all of the feedback and comment from the Community Council as is laid out in this report. Is that correct?
Yes, that's correct. The initial one that was done last year hasn't been shared, but there was a response done to the open period of consultation by Struan Council, and that's what's been included in this report, which I think provided a summary of what previous issues had been raised in their previous consultation.
Yeah, I think it's fair to say there's a great deal of concern in Blair Athol. I think that's the underlying point. Yeah, thank you.
Okay, other questions on this matter? Sally?
So I completely agree with it. I can understand the concerns of the patients. One of the things that I didn't grasp from reading this paper was actually whether there was a risk to Pitlochry services due to the added pressures on the staff that works there. Does that make sense? Because obviously we talked extensively in this meeting about sustainability, about how rural practices have difficult to recruit. We know about the increased workload for GPs, but I just wondered whether there was a context about how the extra pressure from keeping it open, how might that affect the Pitlochry services in the long term? Because the last thing we need is another GP or practice nurse or manager leaving because of the increased stress. And I wonder if there's a way of whether that was something worth reflecting.
Thank you. I'm going to take comment from Sheila McCall and then Councillor Stewart.
Thank you, Chair. I think my first comment on this really is that, and given my points and questions raised in the previous paper about the strategy for primary care services, that this shouldn't be considered as a permanent closure. And I would like to suggest that the authors of the report, if this is going forward to the Health Board, that is the closure pending the outcome of some of the future strategy. on primary care services for that area. And while this is specifically around GP practices, I think this is part of the primary care services that need to be applied there. So I think as a very great area of finality to say that it's permanent. And I think given that we're looking at the overall strategy across Perth and Kinross, we perhaps should soften that language a little bit. I think the other aspect I have is there was a mention here about sole working. I'd just like to understand what the concerns are there about sole working a little bit more, because many of our community practitioners, particularly like the district nurses and community physio and OT, they are lone working and they go to people's homes. So I'm just a little bit confused as to why a lone working situation would be particularly prevalent there. I understand the general concerns about lone working, and I don't dismiss those at all, but I'm just a little bit curious about why that is an issue for the GP practice and not for other healthcare primary care practitioners who go out into people's homes.
Could I? Sorry.
I was going to ask.
If I could just go back to Sal's comments, I think that's important just to answer that, and I didn't get an opportunity to do that. But obviously the sustainability of the GP workforce in Pitlochry is quite significant. We have 2 full-time GP posts vacant, and we have a further retirement pending in the next 12 to 18 months. So and we have not been able to recruit to those posts. We have a short-term locum in the practice. So it's just to put that in context of the workforce. I think in relation to permanent closure, that is not our decision to make. I don't think the Blair Athol surgery has been closed for 2 years in relation to over the COVID period. So but this is about the practice applying to vary their contract in order to sustain the current practice they've got. So I don't think that's our decision to make, but it is something that we can pick up in the engagement work that we will be carrying out around all of Perth and Kinross. So I'll hand over to Hamish about loan working and the issues, and Lisa may have something else to add around that.
Yeah, I'll just pick up on the point that you made there about the contractual stuff. So I'm not quite sure whether it's possible as a comment going back to NHS Tayside Board for them to consider a temporary variance in the contract. I'm not aware that that's possible, but that's certainly something that IG members or elected members may wish to consider passing on as comments. If it was a permanent one, then a new contract would have to, the practice would have to seek an extension of a further change in the contract to now include a premises in Blair Athol again in the future. So I think you're quite right. If it does cease to become if it becomes a permanent measure, I'm not quite sure what options it would be to reopen it up again, even if it was a strategic priority for this group, because the only other option would be to have a new practice completely. And in the current environment, I just don't see that's happening. I think one of the things that we fear is the sort of house of cards problem, or the domino effect, that if one practice folds. So if we, and I'm not saying this is a likelihood, I'm just speaking general terms to be clear, if the Pitlochry practice weren't to be able to recruit and closed, then that would create a very difficult problem in such rural areas in terms of how you cover that service, because Aberfeldy or Dunkeld would just not have the capacity to pick up that, and therefore become a 2C practice. And most practices, I mean, Sal can comment, are struggling to get locums to provide any sort of backfill cover, and how we would run a 2C practice in Pitlochry, I just can't imagine. So there are broader implications for this this decision. In terms of lone working, we used to have 2 branch surgeries in our practice in Crieff, one in Brecon, one in Mewthal. Those closed a number of years ago. We probably do more home visits there, so we're still providing modern services, full GMS services, and only yesterday I did 2 home visits out in Muthil. Lone working was quite difficult because often, certainly, you didn't know what was coming through the door. For single female GPs, that could be not a good thing because they didn't even have reception staff, and I believe in Pitlochry they don't have reception staff in the Blair Athol surgery. Sometimes you're talking about difficult things. Sometimes you're making examinations which you need chaperones for. So my own perception was we weren't able to give such a good, comprehensive, modern medical service within a rural, within a very distant lone working environment without proper support services around it.
Okay, thank you. My real concern is if it's a permanent closure, then it does close the door completely to anything new being at least possible for that size of locality coming out of the strategic plan. But I think we can discuss it further at the health board.
Yeah, Sheila, I think what's going to be really important about in our summation of this is the quality of the comments that will come back from what's been said today. And I think, as Hamish has already said, is there are some that are particular to this closure, but they're also, I'm not, sorry, I didn't say closure, but what I'm saying is about there are particular issues around Blair Athol, but there's also the broader comments that I wanted to pick up on.
Thank you.
And I'm going to bring in Colin now.
Thank you, Chair. I've got a few concerns to raise. I know that staff who were involved in preparing the report didn't have sight of the petition, but just for clarity, the 100 and odd, I think 119 signatures signed up to we, the undersigned, ask Athol Medical Centre to revisit the proposal to close the branch surgery in Blair Athol on the grounds that it is a much needed local service for those who do not have access to transport, including older people, young families and people with disabilities. And that was the petition organised by Blair Athol and Struan Community Council. Now, recognising that the local community council had concerns that the decision had already been taken, I did ask about whether a decision was taken and then the consultation was done in August, September of this year, and I was assured that that wasn't the case, but I have had sight of emails between the practice and the community council, which certainly back as far as January, February of this year talk about we are unable to reconsider our previous decision. We would reiterate the main reasons for this decision as previously reported, and so on. So it does seem to the community, a highly rural area of Perth and Kinross, it does seem that the decision was taken before the consultation was done. A number of the concerns that were raised by the GP surgery, as I understand it, related to the suitability of the buildings, and understand that Athol Estate has never had any problems about the suitability of the buildings reported to them, but they have in any case undertaken to repair the premises, and they would absolutely refute that the premises are in any state of dilapidation. Understand that there were concerns around lone working, but the community in and around Blair Athol and Struan area had actually offered to set up a volunteer rota for receiving patients at the surgery to deal with just some of the issues that Dr. Dougal was referring to, and that the community council again and again went back with suggestions to the GP surgery to try and facilitate making the practice, just as we were talking about in the last paper, try and facilitate making that practice sustainable, but they were rebuffed. I think it's important that IGB members are in possession of that knowledge, because it's not, those aren't details which have come out in the report. In relation to the lone working as well, we can even see in this report that in terms of medical issues, more people will ask for home visits. So there will be more GPs doing more home visits and doing lone working in any case, certainly than they are at the moment when those facilities are not provided in Blair Athol. But most concerning to me, I think, is that in terms of medical issues, more people might put off asking for help until their conditions are so advanced that they have become more serious. And that would seem to me to be a particular concern in terms of actually improving the health of the population. Another point to mention is that Blair Athol actually has a provision, I think, within the local development plan of the Cairngorms National Park Authority for 38 new houses, but it has a significantly higher proportion of those, 45% rather than 25% in Perth, the rest of Perth and Kinross, 45% to be affordable housing. So we will be talking about a more, if you like, economically potentially disadvantaged population, or potentially a vulnerable population moving into those expanded premises. I had sight of a draft of this report prior to the one that's come to us today. The draft that I saw does not contain the part about noting that a full equalities impact assessment is carried out in advance of the decision by NHS Tayside. I would have thought that that is obvious that that should happen, but I would have hoped that that could have happened before the report came to the IJB today for our consideration and comment. And you know, the only sort of recommendation in terms of alleviating the problems that have been raised by the community is the provision of getting the community itself to provide transport, and that is not an easy thing to do anyway, regardless of the actual rurality of the area and the funds that might be available to a community which has already attempted to take quite significant steps to make that GP satellite practice, branch practice, sustainable. So I have extreme concerns, but given that I'm in possession of this information, I wanted to bring those concerns and those proposed solutions from the community out in public today for the benefit of my fellow IGB members. Thank you.
Thank you. It's my understanding that every patient was written to as part of this process. So clearly that's some of the information that we have. I'm mindful of some of the comments that you've also made, Colin, some information that we're not privy to. But I think one of the key issues for me is about the equal opportunities assessment, which is critical to this, because that then would automatically cover areas like access and transport and patients' requirements to be able to go to an alternative provision or to sustain an alternative provision. So I think probably where we've got to with this, and I think we could probably move to the recommendations, but my sense is we need to have a pretty quality comment feedback to NHS Tayside based on the conversations that we've had today from IJB board members, and highlighting some of the areas where we feel that we should have had more information in advance of this discussion, which would have been really helpful. Sorry, Colin. Right. Sandra, sorry, Colin's pointing out that you wish to come into this, but I was just beginning to get more information on it. Sorry, Sandra, come in.
Thank you very much. So I think there are a number of important points, both in this paper and the last one, some of them strategic and some of them really specific. I think the link that's been made or the suggestion that's been made back to housing is really important as far as attracting staff to these local areas. And a point that we really mustn't lose sight of. I understand from the previous paper something like 13% of GPs retiring within the next 2 years, and 30% of local practices have GP vacancies. So it's something, and I think that follows for other staff as well. So it's something we absolutely must make a priority to be able to furnish our staff with appropriate housing. On a more specific perspective, as you might imagine, we've had some feedback via the reference group regarding this topic, and it pains me hugely because of or partially because of what's gone before with the IJB, where consultations can be viewed as having been predetermined, and we really need to put steps in place to ensure that the consultations that are being undertaken are as far as possible, without criticism, because they must be seen to be open, and they must be seen to be reflective, and they must be seen to be transparent. So yes, we've had feedback around, you made the comment, Bob, about each person in the practice having been written to. So there has been feedback about the wording and the way that these letters were written weren't necessarily suitable for the population that they were going to. So maybe this is something that the IJB needs to look at. It's also been highlighted around about the difficulties in prescriptions being delivered, and local pharmacies not being willing to deliver again to any further north than Blair Athol itself. So there are knock-on impacts of this. When I looked at the report myself, the information that's come to light today about the questionnaire that was the local questionnaire that had taken place, that then seemed to make more sense, because I looked at this and thought, why is there such a low response to this? But the fact that there is additional information which really does need to be incorporated now does make a lot more sense. So I would urge the IJB to look closely at what we're doing from a consultation point of view, because this is really important to people's daily lives, and it's not something, and I'm not suggesting it is being taken lightly, but it's something of huge importance, and we really do need to get this right. So thank you.
Thanks very much, Sandra. And it's not I'm not surprised that there are so many responses around about this issue. Evelyn, it's clear that the quality of our response from the IJB is really important, that we capture the things that have been said today. So how are we going to do this? How are we going to do this in a completely transparent way for the board? Because that feels quite important about how this feedback is conveyed. And is that okay? Just a moment, David. So it's really important about how we convey this information back to NHS Tayside as comment and for transparency, so that the general public are aware of what the IJB is actually saying, rather than a summarised account of this particular conversation. So the quality of that communication, and I wonder if that needs to be circulated in draft form before it goes to NHS Tayside, so that we can be assured that the feedback feedback commentary is as we wish it to be conveyed, basically. I wondered if you want to make comment on that. I do know that Jackie's trying to put something before me here. Do you want to say something, Jackie?
Yes, thank you very much. I wanted just to pick up on a couple of points that have been raised. First of all, the Equalities Impact Assessment. We considered this before bringing the report here and took advice. And the advice from our legal advisor was that the decision is one for NHS side board. So therefore, it is for NHS side board to assure itself and to carry out the Equalities Impact Assessment. So it would not be appropriate to do that because we are asked to provide comment. So I just need to emphasise that we did take advice on that. I also want to inform the IGB that and members that the communications and all of the information that was provided, the letters, frequently asked questions, the response card, that all of that was had support and involvement from NHS Tayside communications team. So if we have comments about that, then I feel I need to take that back, not just to the board, but to the team of people who've been involved in this. But it might be helpful to have sight of some of those letters and the content, because we did try to make that as simple as possible. I know the team worked very hard on that. Provided paid postage envelopes, made it in the written form, taking account of the needs of the elderly population, for example, in that area. So there was a lot of consideration given into that, and I'm really just making that comment because some of the comments that have come forward today don't really recognise the extent to which the team have worked together to do this to the best of their ability. So it might be helpful to see the paperwork that is associated with that. Thanks.
Very quickly, I'm completely torn on this. I'm torn between the wishes of the community to keep their surgery in situ, and I'm also torn by the needs of the practice to maintain sustainability, and particularly when it's so hard to recruit. So I'm either in torture over this.
Well, at least we've actually gone around the issues and actually, although Jackie was saying is the Equality Impact Assessment is still to be done by NHS Tayside, there have been quite a lot of equality related questions raised as part of this discussion. So there's that. I still think the quality of what we feed back to NHS Tayside is probably going to be the key issue that captures the key issues that we were referring to. And I'd like that to be in accepting the recommendations, because we're principally being asked to provide comment back to NHS Tayside. I would like to see a draft of that before it goes round. I think the board needs to see a draft of that, and that would need to happen fairly quickly as part of this process. And I think that would provide some transparency, I think reassurance to the board that they're content with what's been conveyed back to NHS Tayside, given the issues that Jackie's also raised as well about what work has been done so far as well, and recognising that as part of that feedback too. Yeah. Are we content with that as an approach? Okay.
Yes.
Evelyn, do you want to make one further comment?
In terms of what we've heard today, are we anticipating that it would be an appendix to the report going forward to NHS Tayside, or we would incorporate it within the paper? I suppose that's my question. Yeah, so we'll take advice. Yeah. Yeah. Okay, thank you.
Sorry, we couldn't hear what Bob was saying there.
Oh, sorry, Sandra. We seem to be in agreement that the report that you already have will have an appendix that will include the comments that have been raised today by the IJB board members to ensure that our discussion is fully reflected in the feedback to NHS Tayside. I think you're nodding there. Okay, thank you. And we accept the other recommendations as well as the feedback. Sorry.
Chair, can I just clarify in relation to the question on the appendix? The report that we have today was a report to the IGB, which sought recommendations for us to note particular aspects of this and to then provide comment to NHS. It might be that a similar report is being submitted to the NHS Tayside board, but I'm thinking that it may provide confusion if we try and append anything to a report. I think the process we've had is we've had a report to our board today. A communication can be sent once it's been agreed by all of the IGB on behalf of yourself to NHS board to take that into account when they're considering it. But I think it might be confusing to conflate any report that we've got and add an appendix, which is our feedback. So the minute of the meeting today will also reflect the comments that have been made, and a written communication can be sent from yourself as the chair of the board once all of the board has considered this.
I'm happy to have a written letter from myself conveying the important areas that are covered today, if that's what meets the requirements for today. Okay. We'll come back for about, I think we need about 10 minutes. Okay then, thank you very much indeed. I hope you've had a break. It's been a really interesting afternoon. We're now going to move to next substantive item, which is item 6.6, discharge without delay. And the Chief Officer is going to do a presentation on this prior to the, is it yourself, Jackie, or is it Evelyn? It's Evelyn's going to do it. Maybe it's because it came from you, that's what it was, yes. So we're going to have a presentation first of all, then Evelyn's going to lead and take questions on it, and I dare say that Jackie will too. Thank you very much. And just worth saying is that this issue will also be discussed at the NHS Tayside Board meeting tomorrow.
Okay, thank you very much, Chair. Yes, what I've attempted to do is just a very short presentation to explain the sort of programme that we have in relation to discharge without delay, and setting that in the context of our delayed discharge improvement work and also our demographics. So the presentation today is just to really update the IJB on the complexity, ongoing challenges and the current position in relation to the management of delays in Perth and Kinross. And I will describe the detail of the delayed discharge without delay programme, and also the work we're doing in collaboration with our PRI clinical colleagues in order to improve our trajectories around this. So Perth and Kinross strategic intent within the discharge without delay programme is to treat where appropriate based on people and place-based care, looking at patient journeys of people rather than hospitals, and delivering right care, right place for every person, every time. So in order to understand where we're at with our discharge without delay programme, we've taken a bit of a look at, and if we could go to the next slide, please, we've taken a bit of a look at our demographics and the demographic changes in Perth and Kinross over the last 2 decades. And we've also taken a bit of a deep dive into our delayed disc performance in relation to bed days delayed over the last 6 years, and trying to understand the impact of the pandemic within that. So I'm not sure, because I don't have my glasses on, how visible that is, but so what this slide is really telling us, in Perth and Kinross, we're dealing with a combination of our population ageing there, and you can see that dark red line moving up in relation to ageing, but also a rapidly growing population as well. And you can see there that our biggest shape and change has actually been in 2021, where we've gone from a growing population of 12.6 to 14% in 1 year. So that's quite significant. So what this is really telling us is that we probably are struggling to keep up with demand and also with complexity in that demand. So what we're seeing is an increased frailer older person post-pandemic, but we're also, and we all know this because we've spoken about it before, is that trajectory of people living with dementia in Perth and Kinross, which is quite significant. So you can see from this diagram, the other thing that we need to be mindful of is the shape of the population is changing, and we have more older people in Perth and Kinross relative to younger people. So to this end, if this keeps growing, what do we need to do? And we've talked around this significantly around what strategies we need to put in place in order to do the best we can, really. Because as you're seeing, the younger population isn't increasing at the same rate. So our human resources will be a big factor for us as well. So if we think about our strategies, you know, we could continue to match resources against escalating need, but as we all know, it's not always the case that our financial ability will be there to be able to grow, although we do look at demand pressures every year with budget setting, but you know, the growth is exponential. So other than that, our second strategy might be to do things differently. But in order to do that, we need a clear vision across all sectors and buy-in across all sectors in terms of the models of care that we are trying to deliver that will make a difference for the people of Perth and Kinross, and we need sign up to that. So that's our acute medical colleagues, our GPs, you know, our primary care services in the widest sense, but how do we start to think differently for Perth and Kinross? And the third strategy really is to remove waste and duplication and to really sort of start to do things differently and prevent those handoffs that we see quite frequently in service provision. So next slide, please. So this is our second slide, and this is really us trying to understand the impact of COVID pandemic, and we have taken a look back for the last 6 years at our delayed discharge occupied bed days from 2006. The pink line here is the pandemic, and there's a dotted grey line. I don't know if most people can see it or not, but that's us matching against Scotland's performance, which has been applied to the size and structure of the population in Perth and Kinross. Jackie.
Thanks very much for allowing me just to come in there, and when I gave my strategic update and referred to the letter from the Cabinet Secretaries, they're asking for our position to go right back to where we were in August 21. So just to keep that in mind.
Jackie. Thanks for that, Jackie. So you can see historically, if we go back to 2016, we had a significantly high bed occupancy rate for delayed discharge, people in delay. And in 2017, a load decreased slightly, it's still high. And then we made some real improvements in 2018, and you can see the difference in our trajectory there, whereas we've gone down and the Scottish line has remained pretty high. So we've done some real improvement work there. However, in 2019 started to climb again. And then at the beginning of the pandemic, we did see a huge drop off. However, what we are now experiencing from around April 2021 is an upward spike. We're still below the Scotland performance line. However, you can see towards the end, we're just beginning to merge again with Scotland. So I think it's really important to sort of just bear that in mind in terms of, you know, the starting point for us. Could I have the next slide, please? So what are we doing to support the response to improving our delayed discharge trajectory? Well, most people around this table will know we've signed off a strategic delivery plan for older people's services last year. And within that, a significant investment has gone through in order to support our strategic themes, which were early intervention and prevention, shifting the balance of care and capacity and flow, including discharge without delay programme. So in order to, and I can't do my glasses and speak at the same time, so excuse me a minute. So in relation to the strategic themes that we've worked on, what we are doing is trying to look at different ways of working in order to change the way things are. So within our strategic delivery plan, we have invested, and you've heard earlier about the Living Well teams in relation to care at home, and this is a brand new model for care at home, but working with smaller rural areas. So we have our Highland area is now up and running, which is fantastic. But it is about encouraging and thinking differently. So it's not 4 times a day care at home. It's working with communities to see what we can achieve, working with volunteers. So, and know Zoe will have lots more information about this if you have questions on that afterwards. So that's one big piece of the jigsaw, as well as commissioning for outcomes with the independent providers. So another big area for change is the development of our hospital at home service, and we are predominantly focusing that on Perth City as we speak. So we've fully recruited to it bar our medical, our medic, which we're interviewing for soon. So very hopeful for that, and I will speak a little bit more about how that will work with our acute colleagues moving forward. And the other area that we've talked a bit about today is how do we enhance a home visiting service for our general practice, and how do we do that as an integrated team across across Perth and Kinross, and we're working with Sal and others around that in terms of how that progresses. So lots of other things within our strategic delivery plan, which I won't go through now, but these are just some of the big ticket items that we're hoping will make that change. So what are we doing over and above that strategically to get ourselves into a better position? We have also approved as an EMT a winter resilience plan, which is, you know, every year we talk about what we're going to do for winter. So this is enhancing what we've already got. It is non-recurring funding. I think we've invested about 2.3 million in non-recurring funding. But what that's allowing us to do is to maintain an additional bed base that we've had open through COVID and retain that till the 31st of March so that we can get ourselves through winter. We have interim placements that we are using, like most of Scotland are, and again, been able to retain those to the 31st of March. We have 26 people in those beds today, and we couldn't really do without them. So it's also allowing us to create additionality in our teams by the use of agency staff for care at home, heart. And this is something we haven't done in the past to the same extent, but we are doing now. And again, building resilience in our health and patient services. And over and above that, just looking at additionality in our heart service to get us through winter. So lots of work ahead of winter. We approved that in, I think it was July or August, so we're really beginning to motor on that. Over and above that, I think Jackie mentioned it earlier, we have reinstated our silver command structure to work on our delayed discharge trajectory. And the trajectory we're working on currently is the number of people who are delayed in acute services. And so far, we're down to amber as we currently stand and heading down towards green by, I think we've got a timescale of around the end of December. So working hard to reduce that acute delay. And over and above that, EMT have commissioned a whole systems dashboard, which Dr. Dougal is leading on. And that's to really consider the whole system pressure. Where are all the pressure points in the system that, you know, so we can really understand our data. Next slide, please. So I just wanted to sort of briefly talk about our discharge without delay programme and the key components that we're leading on. And the next slide will be the key components we're working together with our acute colleagues on and our primary care colleagues. So the key component of the delayed with the discharge without delay programme, they're sort of laid out in the paper, so I wasn't going to go into them in too much detail. But really the programme is really encouraging everyone to look at change and to adopt a changed mindset really, and really focusing on simplifying discharge and applying a pathway-based home first approach. So encouraging all care professionals to question why not home, why not now? And that may sound easy to say, but difficult to do. Lots of organisation development work and improvement work in process in order to be able to change that sort of culture. So what are the key components of our discharge without delay programme? We have our frailty service at the front door, which is allowing us to turn people round and take them out quickly from hospital. We have our integrated discharge hub, which is supporting ward staff with safe and appropriate patient discharge. We have a massive programme of work around planned date of discharge. So working well, it's working well, but more to do. Lots of education from our discharge coordinators into all of our inpatient areas. And we're really working hard with AM and weekend discharges to try and improve our trajectory and working with NHS Tayside Quality Improvement Programme. As I've said, we've maintained the interim beds for the winter period and really having a reablement approach. They're supported by our live active service and our RVS service. So we're not just putting people into beds, we're keeping them healthy and reabling them at the same time. Next slide, please. So this is my last slide, and it is in relation to, I suppose, we can't do this as a HSCP by ourselves. We need to do this with everybody else. So with our primary care colleagues and with our PRI colleagues in particular, actually. And we have had a significant workshop this week with all of our acute sort of medicine colleagues to really start to think about how we can do things differently. And these are some of the suggestions that we have agreed upon and are working through. And I pinched the slide from this week's workshop, so I'll thank Monica for her side. But so we're looking at prof to prof calls, or an element of that. So that is, you know, GP to consultant type calls, so we can get advice and support about who we admit and really ensuring we get the right person to the right place first time. So adding value to somebody's journey. We have an ambulatory assessment area that's been built up in PRI to deliver that sort of early diagnostic work, but also we're agreeing to support that with our hospital at home service. So we're really getting good throughput, so people may come in for the assessment and they will go home the same day. We are developing, not we, acute services are developing their acute frailty bed-based unit, and we will be supporting that with our frailty at the front door service. And then in terms of alternative pathways, I have mentioned our urgent care home visiting service. That's a key part to prevention of admission. So again, that's something that we're really motoring on to try and get into place. And I think we talked earlier about the clinical forum and how we maximise interface working with primary and secondary care. And again, that's something that we're moving forward with. And lastly, it is the sustainability of our workforce and a big message about service delivery with kindness and resilience, because I think that's with everything all our staff have been through, we need to remember this is tough out there. And again, you know, just working together to improve workforce recruitment and retention. There is some international recruitment going on for nursing and AHPs. So again, really trying to think differently and where can we get staff from. So I'll leave you with that, and I'll maybe just go to the recommendations of the paper. So really, it is recommended that Perth and Kinross Integrated Joint Board note the complexity and ongoing challenges on the current position of our delayed discharge services in Perth and Kinross, and endorse the direction of travel within the Discharge Without Delay improvement programme to achieve longer term and sustained progress in reducing delays in hospital for people who are fit for discharge to home or to a suitably homely care setting. Thank you.
Okay, I think we're ready to. Thank you very much for that, Evelyn, for the presentation. You have the paper before you. It's fairly detailed. I'm happy to invite questions. Beth, and then David.
Thank you. It's not so much a question, it's just a comment. Thank you, Evelyn, for your presentation. I think you've covered everything that I would probably ask a question specifically about. I think it's really interesting to see the successes about joint whole system working, and it's good for me to hear how close the work is with the acute, the discharge hub, etc. So thank you for that. The only thing I would ask specifically, you were saying that the trajectory looks good in the sense that you're now in amber and heading to green, you hope, by the end of December. Do you think that's sustainable?
Well, we're hopeful. It's all we can be at the minute. The honest answer is.
But it's looking better.
It's looking better.
Okay, thank you very much.
Thank you, Chair. The last line of your slide talked about staff. How do you can't do much unless your staff are engaged and on your side. How do you measure engagement?
I will bring my senior service manager and Amanda Taylor, because we have done what's the word, a consultation with our staff around that, and I don't know if she's here or not, but hopefully she is. Maybe not. Yeah, we could come back to that if you want, but we could share. We have put out you know, a sort of feeler in terms of how staff are feeling with the whole sort of new ways of working and new programme. I'm happy to share that actually.
I think, Evelyn, you're underselling the approach that you've been taking, and I know that Kenny, as head of adult social work, and Evelyn as head of health, and myself have spent some time, in fact considerably more time than we set out to, because we engaged in some really full discussion with the hospital discharge team, and really, you know, you got into a lot of discussion around what were the inhibitors here and their role in addressing that. So I think it's really just to assure you that we are all engaged in that communication, and it's at every level. Thanks.
Okay, in very, very broad terms, is the feedback that you're getting from staff good news, or does it leave you concerned?
I think the feedback we're getting from staff is good. I think they're engaged in the Discharge Without Delay programme, and it's not just health staff, it's multi-agency staff across the piece, and there's really good engagement in terms of how we're moving forward with the programme, and I think there is an enjoyment in terms of thinking differently and working together with colleagues they haven't worked with before. I think that's really, really positive actually.
I'm going to take Donna McPherson and then Councillor Stewart.
Thank you, Bob. Thank you, Evelyn. And similar to Beth, more of a comment really than a question. But as you were talking, I jotted down the words people and place-based care. And that's really important here, because with delayed discharges, the situation that we have is people backing up within the acute sector, and it's the wrong place for the patient. They're not going to get the specific care that they need, and they're also going to be exposed to risks by virtue of being in that part of the system. It puts pressure on the acute system because there are more people going in than there is space to deal with, and it also creates unbudgeted costs in other parts of the system that you know, and I'm conscious that that is a concern, certainly on the NHST side of the fence. So I think, you know, it's important we look at it as on a whole system basis, and I'm really encouraged to hear that you're doing that, and really just hope that all of these measures can bear fruit as soon as possible, so that we can get the system back into balance just as soon as possible. So really just to welcome the paper. Thank you.
Jane wants to make a comment on budget, Donald.
Thank you, Donald. I absolutely recognise what you're saying around unbudgeted costs across the acute system, but I would also note within the paper the fact that we're highlighting significant unplanned costs within the Health and Social Care Partnership that are having to be managed, and these are extremely significant for our bed-based services.
So really, it's a zero-sum game, isn't it? No one's winning in this one. Yeah.
Thank you. Thanks very much, Donald. I'll now take Colin, and then I'll take Sheila.
Thanks, Chair. I mean, given the complexities of dealing with delayed discharges and the impacts that has right across social care, I wonder if it would be helpful to have the report forwarded, or possibly the presentation presented to members of the Council's Health and Social Wellbeing Committee?
I'm happy to arrange that, Councillor Stewart.
Sheila McCall.
Thank you, Chair. And firstly, I'd like to thank the authors of this report. It's really welcome, and it's really good. While I accept that the majority of delayed discharges are probably due to people who are older and more frail, there may also be people who perhaps live alone and are following perhaps an elective surgery but need support at home to be able to go back and function. So one of the proposals initially for Beechgrove House to be brought under consideration was the possible use of it as a step-up, step-down facility while someone's home environment was made ready and their necessary support was put in place. And whereas care home places are often very difficult to find. So I'm just wondering if any consideration was made to that type of provision.
Okay. Yes, this has been in consideration for many years, Councillor McCall, and we have experimented with step down in many different varieties actually within Perth and Kinross, including Beechgrove House, Leaving Glen, etc., etc. And we have trialled it. We've struggled really to find the right type of client for that step down facility. Certainly, you know, and in Perth City. So, you know, we use our community hospitals for step down within rural areas, and we use Tay Ward, which is our medicine for the elderly ward, as a sort of step down for Perth City. You know, it maybe doesn't work as well as it could, and we certainly need to be looking at that more. I was challenged around this when I met with the consultants in PRI actually, in terms of, you know, how we could do that, but it's so complex because number one, we need to have the numbers of care home placements available, and you know that is tighter and tighter as we move forward. But it's certainly something that we would still be mindful to look at, and we have talked around this at our older people's programme board. So I'm happy to take that back to have further conversations around it. But it's just not a straightforward proposal. We need to work it through.
No, I fully appreciate it's not very straightforward at all. I was loath to almost ask, but I thought it'd be worthwhile, you know, throwing it out there. The only other question I have really, if I may, Chair, is just to try and get a sense of the delayed discharges. Are these mostly patients who come in under an emergency admission, or is there a mixture of emergency and elective admissions?
I would say the majority would be emergency admission. Very seldom would we have delays in and around orthopedics or, you know, elective surgery. You may have the odd one, but it wouldn't be significant compared to those that come in under an emergency admission.
Yeah, that's comforting to hear. I'm thinking in particular with the elective unit that's hopefully going to be coming to fruition at some point, that the pathway to care, but orthopedics is a good example because very often people do need some support and their home may not be ready, but you can start planning for that a lot earlier, I suppose.
Absolutely, there is a trajectory for that from the outset. Yeah.
Okay, well, thank you very much. Thank you, Chair.
Thanks very much. I don't have any more questions, but someone just popped up. Amanda, I'm not sure if the question is now relevant, Amanda, but it was to do with staffing engagement.
Amanda, we were just talking about the survey of our staff around the Discharge Without Delay programme and, you know, how they were feeling about being part of that.
Can you hear me okay? Sorry, I'm having a bit of technical issues here. Thank you. So yes, I think we've done quite an extensive survey and engaging with the staff. So the question, I think, is related to how the staff are feeling about that engagement. Is that right, Evelyn? Thank you.
Yes.
So I think we're in a process now. We've just had a very successful event there this afternoon, meeting with some staff. They're feeling engaged in the process. I think they're beginning to understand what we're trying to achieve strategically, and I think we're offering education sessions as part of our approach. With our teams, so we're working around the themes of planned data discharge, discharge without delay, home first. What does that mean for people, and what does that mean for the teams, and how do they have to change their practice? So, yeah, I think we're in a good place. We're starting to engage. There's lots of work to do, and I think we've got a good plan now in terms of a way forward. If that answers your question, you've maybe already said that, Evelyn. Apologies if you have.
No, that's okay. Thanks, Amanda. I just needed confirmation.
Thanks very much. I have no more questions on this matter. Can we note the recommendations? I won't go through them. Are we content with that? Thank you. That now takes us on to 6.7, the Strategic Planning Group draft minute, and the report is available there for your information. A very brief introduction to this. I'm conscious of time now.
Okay, so this is an overview of the minute from the Strategic Planning Group, where we looked at 3 topics of conversation around local housing strategy consultation, self-evaluation of community engagement, and co-designing for the future is what we termed the final session. Hannah Kettle's Planning Policy Officer came and gave us an overview of the development of a local housing strategy and the main challenges that present within Perth and Kinross, including demographics, demand for complex adaptations, rural nature of Perth and Kinross housing stock, and fuel poverty, and gave us an overview of the consultation activities to date and the consultation activity that was due in August and September, which is now completed. The ask of the group was just to share communications regards that consultation, which the group agreed to do so. And as I say, that consultation period is over, and we await the final draft, or the final local housing strategy. We then went on to talk about the self-evaluation of community engagement, which we've spoken at a previous IJB around. This was our first session looking at domain number 1, which talked about ongoing engagement and involvement of people. Strategic Planning Group split into 3 groups and came back together and produced feedback, which you'll find in Appendix 1. There's a mixture of feedback. I would suggest not anything that we were particularly surprised about. There were some really great examples of very, very good engagement, but across the board, a sense of needing to improve, in essence, to be engaging and consulting at an earlier stage in order that the people who use services are actively influencing service design as we move forward. That information has been sent out to the groups that are represented in the SBG for feedback, and that's ongoing. Subsequently, we've gone over domain 2, and the next session is for domain 3, at which point there's a proposal that the IJB and the Strategic Planning Group work together on that one, as it's around leadership and governance, and we'll send out a communication with regards to that. We then had a session from Moira Gill, who's a learning development team leader and has a specialism in co-design, and Gillian Charlson, who is a mum of a disabled young man, but also works in a local community organisation supporting people with learning disabilities. They've been engaged in a piece of work. Well, Perth and Kinross were selected amongst a few other local authorities to engage in a bit of work with iHub. Moira gave us an overview of the Scottish approach to service design and the importance of that and what the vision of that was, and that the people of Scotland are supported and empowered to actively participate in definition, design and delivery of their public services, from policy making to live service improvement. She gave us an overview of the actual project that the team are involved in, which is around learning disabilities and looking at redesign of day services. A very high level aim to transform delivery of day support for adults with learning disability and/or autism to best meet the needs of individuals and their families and carers. Moira then went on to discuss a series of events that are planned throughout the rest of the year, called Learning Disability Day Opportunities Jams. There's a link in the paper that you can have a look at, and you can engage with that activity as well. Gillian spoke really eloquently at the end about her involvement in this process and how it's been different for her in terms of engagement to previous engagement that she's been involved in, that it was a much slower process, but that actually was much more meaningful, and that she felt that her views, her son's views, other parents' views were being meaningfully heard. So it was a really, really good example of a piece of engagement activity that's worked well, that we're doing the right thing with. So it was something that was important for us to kind of learn from, and we will use that and reflect on that in terms of our end goal with regards to self-evaluation and what it is and what we do and how we plan to do that as we move forwards. I plan to run some focus sessions with regards to the self-evaluation, and we'll get in contact with, for example, the Third Sector Forum to do some specific engagement around the domains that we've already covered. It's been really challenging for people, I think, to feed back, and I think if I do something in a more organised way, it might help get that. And as I say, you'll get that full feedback and end of evaluation by February, March 2023.
Thank you very much. Are there any questions? Thank you very much. You know, I think we should start thinking of Star Awards for some staff. You know what I mean? You just think about just thinking if NHS Tayside can do this for staff, and the whole issue about staff is really critical going forward here. Sally.
No, it was just in response to the brilliant work that Moira's done, is that the group's been invited to showcase it at an event for NHS Tayside about person-centred care. So that's just brilliant, and it's just nice to have someone from Perth and Kinross showing off for NHS Tayside.
I'm glad my point's not been lost on this, but I'll think about this. Right, okay. Thank you very much indeed. Thank you. And that now moves us on to finance and audit and performance. And we have 7.1, a verbal update from the Chair of Audit and Performance Committee and the Head of Finance and Corporate Services, Beth.
Thank you for that. I'm aware of time, but I think it's worth giving a quick run through. It was, I think, modestly a successful event because there was a large number of the membership were there for the first time. And I think we had a good run at the agenda and a good look at the papers, which we had a good discussion around. I know that Jane's going to talk to the annual accounts in the next item, so I won't focus too much on that. But I think one of the things we looked at was that the lengthy papers that we saw at the meeting, including the annual performance report. And I think there was a lot of discussion around the group around how accessible that was, and we looked at, whilst it was really good, how do we use it? So there's a bit of an emphasis on how we use the information and how we take that forward. We looked at strategic risk, and then we looked at the partnership improvement plan and the audit recommendations, which had been integrated into a new document, one new document. Taking all these documents on board from a first time perspective from all of us, we were able to give that view of saying, well, is this accessible to everybody? And is it giving us the right information in the right way? We also had the report from the internal audit and the external audit. So the internal audit was useful. We were able to have a good discussion with internal audit about a programme for next year, including some discussion around how it was used to support governance, etc., within the IGB. We then went on to look at the external audit report, which is Jean may be talking about further, but there were a couple of items that were raised by external audit, one being about the latest integration agreement and some issues around that and shared risk. And Jane, as a Chief Finance Officer, I think has already taken some action around clarification of that. And the other was about the clawback of the funds for COVID, which we've alluded to earlier on in the meeting. The other big issue around discussion was, I think Sheila, it was you that raised about the cost of the external auditors, and and you had experience of that. So we'd received some information recently from the external auditor saying quite similarly to what you had alluded to, that the costs were going to go up. We didn't get any details about what the costs would go to, but we did get costs. So you were ahead of the curve with that one, Sheila, so well done. And then we talked about clinical and care governance. There's an item, clinical and care governance was kind of towards the end, but it was unfortunate we didn't have anybody from clinical or care governance that could talk to the paper, and I think that's a huge aspect of that meeting if we were looking at our performance. So I think through the discussion we agreed that it might be really useful, taking into account the amount of information and at the different bits that are being presented to us, that we have some kind of development event around what information gives us the most information, how available it is, how accessible it is to us and to the wider people that are interested in stakeholders, etc. So I think that's going to be issued in the future. So that's a very quick run through, bearing in mind the timescale, but my colleagues around the table that were at the meeting, if there's anything I've not highlighted or you would want to mention, I'll happy for you to give your feedback. I'll take that as everybody's happy.
Thank you. Can I invite Jane to make comment as you'd indicated?
Thank you. Thanks, Beth, and thank you, Chair. Recognition at the meeting of the scale and complexity of the agenda, and Beth referred to that. I think unfortunately that was unavoidable for that particular meeting due to the cancellation of the meeting in June, the need for the annual performance report to come forward, and the need for statutory items and irregular assurance reports to come. So it was huge, and I think new members had a lot to take in at that meeting, and I think there's a reflection around the kind of development requirements of our Audit and Performance Committee members moving forward, which we are giving some significant thought to, and we'll want to consult with the Audit and Performance Committee members in that respect. Beth referred to the external audit report and the recommendations within that, one specifically around the clawback of the COVID reserves, which I've already responded to, but other in relation to the revised integration scheme, and concerns being raised by external audit around the wording contained within the revised scheme around financial risk share, the wording and concern being raised that the wording leaves the IGB exposed in relation to its future financial sustainability. And just to clarify that, what the new scheme does is it leaves it open for the partners to decide if they want to move to a proportionate risk sharing arrangement. But what it doesn't then go on to say is what the backstop is in relation to that financial risk share should the partners not come to any agreement about whether they are actually going to move to proportionate share, and that leaves a kind of a space where there could be disagreement, and that has been raised with the legal advisor to the IGB, and I think we're now looking to kind of raise that through the Chief Officer to NHS Tayside and Perth and Kinross Council formally. They may not be minded to change the scheme, but it's incumbent on us to raise the risk that presents to the financial sustainability of the IGB moving forward. Just to say that was a issue that was raised by me personally during the ongoing development of the scheme, but for whatever reason it hasn't been taken on board in any changes that have been made.
Thanks, Jane. I have a question from Colin.
Thanks, Chair. I just wanted to return to something that Mrs. Hamilton said, that there was an item on clinical care and professional governance on the agenda, but there was nobody there to answer questions about it. Do you want to expand on that?
That's correct. Unfortunately, there was no clinical staff there at that meeting for us to be able to really have a debate and a discussion around it. So it was something that we highlighted. It was important. If that was the forum that we're going to discuss performance, particularly clinical care governance, we will need to ensure that there is somebody present to make the data sensible and the discussion appropriate.
Thanks. And can I just check that
Yeah, no, thank you very much for raising that, because I know that I was on leave at that particular meeting. Otherwise, I know that I would have been there. But the point, if there's a report being produced that's about clinical and care governance, the relevant personnel who are responsible for that and can answer questions need to be there. And we have a management team, so we will ensure that we cover that in the future. So I apologise for that.
Thanks. I'm aware of how far back the IJB has been discussing matters of how to achieve proper assurance and oversight around the issues of clinical care and professional governance. Originally, there was going to be a committee set up separately to cover that in particular, and over the following few years it gradually morphed into an agenda item for Audit and Performance Committee. I think this was probably the first time it was on the agenda for Audit and Performance Committee. Oh, I beg your pardon, the third time. So it is clearly important that we do have people there to answer questions, but thank you to the Chief Officer for her assurance around that.
Thank you. Do you have any further questions for Beth or Jane on this? I don't see any. Thank you very much indeed for that update. That now takes us on to the Perth and Kinross Integration Joint Board Audited Accounts 21-22. Jane, do you need to say anything to this? Sorry.
Not really. They have been approved by the Audit Performance Committee. That is the role of the committee, and they've now been signed, Bob, as you know, by all relevant parties, and they're really just with the IJB for information today.
Thank you very much for that. And similarly, 8.2, the comment for us.
Yeah, and can I just record thanks from the Audit Committee for the enormous hard work of the finance team in preparing those audited accounts. I'm sure people sweat and do all sorts of unpleasant things to get them out. So thank you very much.
Thank you for that, David. I don't know what the unpleasant things would be. I'm sure there can't be any, but thank you. But I think the point is well made, and thank you for making that comment, actually. Thank you. Yes, we're now moving on to 8.2, the Annual Performance Report 21-22.
I wasn't seeking to say anything other than just following on from Beth's comments, which it was fully discussed at the Audit Performance Committee, as is the role of that committee. But Jackie may want to make some further remarks.
Sorry. It's a very full report, and I know that there were a lot of discussion at the Audit and Performance Committee in terms of the extent to which this gives a full perspective on the work of the last year, and some questions around how this might be presented in a way that is accessible. So certainly we will take on board those comments, but it's a very full report that provides a huge amount of detail, and I know that there have been a lot of people providing information to this report. So very positive report given the circumstances in which we've been through over the last year. And you know, this is a credit to everybody who's working in the health and social care arena in Perth and Kinross, and to those who've put the report together for us. But there is something about the accessibility of this to the communities and that communication and engagement that we've been speaking about, and how we ensure that we get that message out to the community, and take on board some of the comments that have been made today about ensuring that the public are as engaged in the discussions that we're having today, and understand the direction of travel that the IJB is taking forward. So really just thanks to everyone involved in preparing this report. Thanks.
Thank you very much. I'm going to take Beth and then Colin.
Sorry. The feedback of the discussion was generally positive, and there was acknowledgement of the amount of information. I think I personally thought it was very well laid out in the different areas and categories, so people could access the information that they required. But I think what was important is we acknowledge that this is a multifaceted document. It's hopefully going to be used in various venues and arenas for different purposes, and it's about how we use that to maximise. We can take chunks of it for different groups, linking it to different strategies, and using it as a way of engaging with people. I thought the infograms particularly were good. So it was generally acknowledged, and we talked to service user reps and the carers reps to get their feedback as well. So I think it's not a negative statement about the document at all, but as acknowledgement that at first glance it's very comprehensive, quite wieldy, until you start to pull it apart of how it's going to be used in the future. But again, I would thank everybody for their contribution, and thank David for kindly thanking the finance department. I should have. Thank you, David. Thank you. Thank you.
Colin.
Thanks, Chair. Given that we are a health and social care partnership, I was wondering how, perhaps this isn't a question on the content of the past annual performance report, but I was wondering for future performance measures, whether there are any measures that we could bring in to report on in terms of population health or public health. Could we do something about, could we set ourselves a target of reducing the incidence of type 2 diabetes and report on that, or potentially, improvement in the management and compliance for other long-term health conditions? And I was wondering, that might be an area which would actually bring, real focus to something that should be key to us going forward.
Thanks very much, Colin. That's actually, there's quite a lot of heads already looking at this particular issue, and that's why Emma Fletcher's involvement with us. Jane, do you want to add anything onto that?
No, I just wanted to, it's probably tying with what you're about to say, Bob, but what the aim of the performance role of the Health and Social Care Partnership is to report on performance against approved strategies at the IGB, so that we can come and assure you that what we said we were going to do is making a difference. So any performance report in relation to what you're articulating, Colin, would need to come on the back of something that the IJB would agree by way of strategic direction, and that ties back to Emma's role on the IJB and what the IJB's role is in terms of setting strategic direction against which we can then measure performance. Performance shouldn't sit in isolation. It needs to be tied to agreed strategic direction of the IJB.
Thanks very much indeed, and I'm hopeful that when we come to that discussion, that Emma Fletcher will help us to lead on that, because it's so critical for our lead role as an IJB in terms of promoting public health. So thank you for that. We now move on to the For Information Integrated Joint Board Reporting Forward Planner, which you have before you. And if anyone has any comment to make on that, please do so now. And then we have helpfully set out the future meeting dates and the future IJB development dates as well. So these are all there for information. Okay, well, I just want to conclude, it's been a very busy meeting today. I think probably it's been Primary Care Day, be fair to say, and actually that's not a bad thing. And I think because it's, I would say it's the touchstone issue for people. It's their first point of contact invariably, and it's that critical. And I believe it's one that we will be coming back to time and time again. And I was very taken not just with the individual circumstances around the Blair Athol issue, but also about the broader issues that we're trying to deal with in terms of a new provision as well, which I thought was actually quite helpful too. And I think we need to be optimistic about these things as well. So I just wanted to say that. Thank you very much indeed. And we'll I'll see you all again at the next meeting, which will again will be a very meaty session as well, with a lot of discussion on budgets. Thank you very much indeed. Thank you. And thank you everyone online too.